At this point, please stand for the invocation and please remain standing for the singing of the national anthem and the DOH hymn.
Iisang bayan, iisang hangarin, nagkakaisa sa pananampalataya, bayang maluwalhati, bawat hakbang sabay-sabay, bawat pangarap abutin, kapit kamay hanggang wakas, walang susuko sinuman. Iisang bayan, iisang hangarin, nagkakaisa sa pananampalataya, bayang maluwalhati.
Mga kababayan, ang pambansang awit ng Pilipinas.
Bayang magiliw, pelas na silanganan, alam ng puso, sa dibdib mo'y buhay. Lupang hinirang, duyan ka ng magiting, sa manlulupig, di ka pasisigin. Sa dagat at bundok, sa simoy at sa langit mong bahaw, may dinataraw na kailan pa may di magdidilim. Lupa ng araw ng walhating pagsinta, buhay langit sa piling mo. Aming ligaya na pag may mag-aapi, ang mamatay ng dahil sa'yo.
Please be seated. Good morning, ladies and gentlemen. Welcome to the second Regional Cancer Summit. Let's welcome your host, Ms. Zaggy Gonzalez.
Hello! Good morning, everyone. Okay, a pleasant morning to each and everyone. Today is another remarkable event of the Department of Health Central Visayas Center for Health Development, together with our supportive partners, Vicente Soto Memorial Medical Center and also Ramon Aboitiz Foundation. And I am grateful to welcome you all to the second Regional Cancer Summit here at Sarrosa International Hotel, Cebu City. And I am Zage, one of your hosts for today's activity. And for information of everybody, we are currently live in Facebook through the DOH Central Visayas Facebook page. And please look at the QR code sa inyong respective tables to access the evaluation and the forms for today's activity. And to formally start the event, to give his warmest welcome remarks, let's welcome the OIC of the Local Health Support Division, of the DOHC VCHD, let's welcome Dr. Van Philip Baton. A round of applause, please.
Thank you, Saj. So to everyone, maayong buntag, no? Speaking here in behalf of our regional director. So to our partners from from the Department of Health Central Office, no, for coming over. To our partners and colleagues from our partner hospitals, especially Vicente Soto Memorial Medical Center, representatives from other partners such as our local government unit partners, our NGO partners. Maayong buntag sa tanan. It is a great honor to welcome you all today as we gather with a shared purpose to strengthen cancer prevention, detection, treatment, and care for people within the region. Cancer remains to be one of the most significant health challenges of our time. But today's summit reminds us that addressing cancer is not just a work of a single institution or sector. It requires a whole of government and a whole of community approach, bringing together national government agencies, hospitals, local governments, civil societies, and communities. Under the UHC, we are moving towards a health system where services are integrated, accessible, and centered on the needs of every Filipino. This means ensuring that cancer prevention, early detection, and treatment services are not only available in major hospitals, but are also strengthened at the local level where communities live and seek care. In the region, we are proud to see how local initiatives are making this vision a reality. Community-based programs such as Puro Kalusugan, which is a flagship program of our Secretary of Health, demonstrates how health promotion, disease prevention can start at the grassroots level, empowering families and communities to take an active role in protecting their health. Equally important are strong partnerships, the collaborations with organizations such as the Ramon Aboitiz Foundation Incorporated, or RAFI, more coordinated and more humane for every Filipino. Again, on behalf of our regional director, Director Joshua Brillantes, and the entire team of the Department of Health, Central Visayas Center for Health Development, I warmly welcome you all to the second regional cancer summit, and I wish everyone a productive and meaningful discussion as the day progresses. Again, daghang salamat ug maayong buntag sa tanan. Buntag sa tanan.
Okay, thank you so much. Okay, thank you so much, Doc Baton. Okay, so let's welcome my co-host, Dr. Jobel.
Hello, everyone, and good morning. Welcome to the second Cancer Summit. And my partner and I are very happy to welcome all of you. But of course, before we proceed, let us first say hi.
Say hi to our VIPs.
Yes, to our VIPs.
First, let's acknowledge Mr. Vincent Somerguido. A applause, please. Next, Dr. Van Philip B. Baton.
We have here Mr. Rolly Villarin, Engineer Miguel T. Herson. Hello, welcome.
And Dr. Antoinette R. Albito.
We also have here our Chief of Clinics from VSMMC, Dr. Reynette Ligaray. We also have Dr. Ferdas Galbo. Hello, Doc. I know there's still a lot of time to pinpoint and greet every individual present here today. By being here today, you are remarkable.
Yeah.
Because you are making time for cancer, not just on the other end of the spectrum, but more importantly, helping each other in the innovation towards eliminating cancer, preventing cancer, and doing what's best not only for the patient, but also for their families. So let's continue.
Yeah, okay.
All right, so at this juncture, we will have a message of support from our very own representative from Vicente Soto Memorial Medical Center, our Chief of Clinics, Dr. Reynette Christine J. Ligaray. A big round of applause, please.
Ako sang ipon pila ni ka-pages. Okay, anyway. So my role today is to deliver the message of support from the Apex Hospital, Vicente Soto Memorial Medical Center. Maayong buntag kaninyong tanan. Maayo bata? No, we should be. We are here. We have to be healthy for others who are not as healthy as we are, no? So on behalf of Dr. Gerardo M. Aquino Jr., the Medical Center Chief of Vicente Soto Memorial Medical Center, I welcome our partners from the Department of Health Center, Central Visayas Center for Health Development. Our keynote speaker, Mr. Vincent Somerguido. Sir, I'm glad to see you today. The VSMMC Cancer Center team, led by Dr. Ferdes Galbo. And I think most of the team are on the right side. And all our delegates, presenters, and guests to the Cancer Summit 2026. Cancer remains a leading cause of morbidity and mortality in the Philippines. But what makes cancer more lethal than it is the rather fragmented. All we need to do is to come together and make access across prevention, screening, and detection, treatment, and supportive palliative care seamless, and it entails health against cancer, where evidence-based policy supports clinical and operational performance, where financial risk protection is felt across all stages of the cancer journey, and where the patient is the compass of treatment and policy. That is the challenge we face today, brings together clinicians, public health officials, researchers, and patient advocates to translate evidence into practice across 4 priority areas: prevention and screening, early and accurate diagnosis, multidisciplinary treatment, and patient-centered supportive and palliative care. As the Regional Referral Center for Cancer, Vicente Soto Memorial Medical Center commits to implementing evidence-based screening protocols and track trust and reliance on our service. No? As we jokingly say in Vicente Soto, nothing is enough. No? In Vicente Soto, nothing is enough. No? So as we expand, patients also come in, more patients come in, and just nothing is enough. Looking forward, we are preparing to open and operate additional advanced technologies that will further enhance our capacity to serve. These include brachytherapy, our SPECT-CT, PET-CT, and cyclotron. We are so excited with this one. We are already at the late stage, no? We're so excited to start already accepting patients with just a few more steps, no? We need to comply. These upcoming services will significantly improve our diagnostic and treatment capabilities, ensuring that our patients receive world-class care right here at our center. We remain committed to expanding our reach, strengthening our services, and continuously innovating to meet the needs of our patients. Together with your support, we will continue to build a cancer center that is not only responsive to today's challenges, but also prepared for the future. But what preparation do we need, no, for the cancer that's really growing and growing as a problem? I encourage every participant to convert today's discussions into concrete actions, pilot projects, shared protocols, training schedules, and measurable targets. Collaboration across institutions and disciplines is essential to scale improvements that will reach patients where they live. I extend our appreciation to the organizers, speakers, and attendees for investing time and expertise in this summit. On behalf of Vicente Soto Memorial Medical Center, I wish the Regional Cancer Summit 2026 a productive and impactful outcome. May the partnerships and plans formed here lead to measurable improvements in cancer care across our region. We long to see the day when our patients, no matter their socioeconomic background, will no longer resign to cancer, but stand up to it and against it. Because every Filipino deserves first-class cancer care. Because at VSMMC, kalidad nga serbisyo among garbo. Daghang salamat.
Okay, Doc. Thank you so much for the updates and key points. It really determines that amidst challenges, the fire from the unending support of different agencies, especially from Vicente Memorial Medical Center, is still burning. Because like our theme for this year's summit, cancer can't, but we can. Okay, moving on. To give the overview of the program, let's welcome the medical specialist from the Vicente Memorial Medical Center, Dr. Fergus E. Galbo. A round of applause, please.
Thank you for that. Good morning, everyone. Mayong buntag, and it's nice to be here. See you, all my colleagues, in the forefront with regards to cancer care. Thank you again for giving your time and efforts in solidarity against the terms of cancer. We had our first Regional Cancer Summit last year, and for this year, we are planning to hold it every year. Hopefully, we can rotate it in other parts of the region. Bohol, maybe next year, and other cities. So that's our plan. It will be an annual event already with regards to awareness and updating our colleagues. Okay. For this, for Mergido, the status of cancer program in the region, especially with regards to breast and cervical cancer screening that will be given by Ms. Saraville Villas-Spin. The PhilHealth Yaka program. This is in congruence with our, as mentioned by our previous presenter with regards to LGU empowerment. It's not just the Apex Center that will be handling this. It will be from the LGU, especially the screening and the prevention. So that's what our purpose with regards to Yaka program. And also with regards our new CSP map site provider, which is the Governor Celestino Gallares Memorial Medical Center. There are cancer program updates that will be given by Ms. Carmel Lopez. Also, with regards to most of us, if our patients will ask regarding what's new regarding nausea, vomiting, hair loss, and all those effects of radiation, it will be presented by Dr. Jamila De Vera on myths and facts of chemotherapy and radiation. Also, with regards to the shift in the cervical cancer screening, it's not only pap smear, it's not only VIA, but we're shifting now for HPV DNA testing, more so with regard to self-collection. It will be discussed on updates on cervical cancer screening by Dr. Karen Chris Balbosa. And also start empowering local health unit, current trends and future management of breast cancer. As mentioned, start from the health center. So hopefully we'll be able to cascade what you learned to our unit, our health care unit, the health center, that will be given by Dr. Plan de la Peña. And this month is what you call Colon Cancer Awareness Month. So Colon Cancer 101 will be discussed by Dr. Sergio Angelito Orlesa. And definitely, it's not only what we call holistic approach, not only with the treatment, but also prevention. Fuel to Fight, Nutrition for Cancer Prevention, that will be given by Dr. Ruth Chanko. Not only in the adults, but also we have to be aware with regards to the young adults, young patients having cancer. So red flags in childhood malignancy to be given by Dr. Hazel Valerie Yu. And also there's what we call cure some, if not always, but definitely comfort and compassion always. The End of Life Care, Compassion in the Final Chapter of Life by Dr. Mark Vincent Lucero. We'll have hopefully a representative or hopefully the governor will give our support. Governor Pamela Baricuatro will be here later. Cross our fingers so that we can give she can give our support to from the province to our cause. We have also our updated cancer program design. As mentioned, this endeavor is not only from DOH, not only from VSMC. We're pulling also one of our best NGO, the Rafi Ramon Abuetes Foundation Incorporated, with regards to their updates on cancer program design. It is best that all LGUs will be aware with regards to the support of Rafi. Hopefully, you can incorporate this in your cancer prevention. This will be presented by Ms. Rayleigh May Gio. And definitely presentation of best practices. We have here from Mandawi City, their community-based cancer navigation. That will be presented again by Dr. Debra Katulong. This LGU community-based cancer navigation is we copied this idea that hopefully we can have our community-based navigator workshop in mid of this year together with DOH. We can invite you to have this so that one of the gaps of the cancer management is from the detection from the LGU and to the going to the hospital, to the APIC Center, the VSMMC. So that gap with regards to navigation is one of our things that we have to address. So hopefully we can have this workshop, the community-based patient navigator within this year. And also part of this is part of our most profound members of our NGO is the GPIGO, together with Ma'am Julie Pasi. We will present with regards to the CLAMS program for Cebu City that will be presented by Dr. Vanessa Tawi. And definitely all our management is what we call patient-centered. A sharing of cancer journey by Ms. Emmeline Fernandez will be given later on. And we'll have awarding of top performing LGUs that will be from Rafi's category. Okay. Hopefully we'll have a good learning cancer summit for today. So again, our project is for this year with regards to in cooperation with Rafi, DOH, and VSMC will be the community-based cancer navigation workshop, and hopefully we'll have the hospice and palliative care community-based workshop also within this year. We are hoping the support of Rafi and DOH with regards to our plans. So again, I am Dr. Ferdes Galbo of VSMC Cancer Center in solidarity for the prevention, screening, and management against cancer. Thank you.
Thank you so much, Dr. Galbo. So yet again, we have been given an overview of what will be happening today, the lectures and the flow of the activities that we will be seeing, hearing, discussing, and experiencing. So I hope all of you are excited for today's activity. And so to continue, to give us the National Direction of Cancer Control Program vis-a-vis the expression of solidarity, please help me welcome the Supervising Health Program Officer from the Disease Prevention and Control Bureau, Cancer Control Division, Mr. Vincent Sumergido. A big round of applause, please.
Thank you very much, Doc. And good morning to everyone, to Dr. Baton, who's leading the Center for Health Development, and Dr. Ligaray, who's also leading the team from Vicente Soto. I remember Dr. Ligaray, we first met in Caraga. She was leading the team of Cebu and Vicente Soto because during that time, Caraga was asking for help. Kasi wala po silang cancer access site. They don't have even any facilities that is strong enough to provide cancer services. So they were asking from different regions, Davao and Cebu. And Vicente Soto was there to help Caraga. And they are already actually, Caraga right now has already an access site. So malaking tulong po din yung nabigay ng Vicente Soto to the region in Caraga for the past few years until they were able to have their access site already. So I just came from Tacloban. We were also having a monitoring yesterday from Tacloban sa Eastern Visayas Medical Center, and we also learned a lot from them, especially on how they also improve the different cancer services. And I hope in the next few slides, I'll be able to, share with you some of the things that are happening already across the country. And possibly, makikita nyo din po dito, saan po kayo pwedeng makatulong sa atin, in this big fight against cancer. So while I was making my slide last night, naisip ko ang tagal na pala na enact yung cancer law. It was in 2019. So it's already around 7 years when the National Integrated Cancer Control Act was signed by the then President Duterte. Pero the past 3 years were actually really frozen. Wala pong nangyari after the signing for the next 3 years of that. Kasi it was really pandemic. And it was just only in the last 2 to 3 years from right now na biglang ang dami pong ginawa na nakagalaw na po tayo and tumaas po yung budget natin. And that's the story probably and the lessons that I would like to share to you in my next few slides. So the first thing that I would want to share with you is in terms of working with cancer, ang laki po ng tulong when really put that kind of intervention towards governance. And a lot of regions are already putting premium to, creating a multi-level governance mechanisms in their different regions, in their different cancer centers. So makikita nyo po dito, in some of the regions, they have already started localizing the National Integrated Cancer Control Act. And when you say localizing, they're really trying to, merge from the community up to the tertiary level of care. And it also started from this kind of forum. Itong ginagawa niyo pong Regional Cancer Forum. And wherein all stakeholders are joining, and stakeholders ultimately see, ano po yung need from them. And they started already pitching their things na, okay, we will cover this, etc. And then, in some of the regions right now, that kind of conversation, that kind of dialogue with the different stakeholders has also created sustainable financing. So for example, in Quezon City, meron na po silang local ordinance in Quezon City that's really funding cancer control program. In a way, they have this kind of money that it is also patterned to the National Integrated Cancer Control Act. So in the NICA, there's what we call the Cancer Assistance Fund. In Quezon City, they also have that kind of money to put for that Cancer Assistance Fund and also procurement of medicines and also testing kits. So ganun po yung mga nangyayari po in the different regions right now. And I hope Cebu City or Cebu province probably will also be able to follow suit in terms of providing that kind of multi-level governance for cancer care. And we also started, working and going around the regions to touch base with our different hospitals. Kasi doon lang po namin nakikita ano po yung need ng different hospital. In fact, earlier, I was talking to Dr. Ligaray when we were in Eastern Visayas Medical Center. We learned a lesson from them, na in Eastern Visayas Medical Center, they were able to have this partnership with the Toxic Care in Quezon City na kung doon nila i-refer yung pasyente for PET scan, there's a airport-to-airport transportation for patient, and it's paid with the Cancer Assistance Fund. So all of these things, these are some of the small interventions and innovations that our different hospitals are actually doing that probably we can also share to the different regions across the country. Then another thing that I also wanted to emphasize is the point na sa dami-dami nating cancer patient, definitely government cannot do it alone. Hindi po kaya yan ng gobyerno. Kaya public-private partnership is really a critical intervention in order for us to increase access to cancer care. So for example, the story I've mentioned earlier about the first time I met Dr. Ligaray was in Caraga, because Caraga during that time, I think it was in 2024, they were trying to navigate their patients from their regions to the other regions just to access, chemotherapy and radiation therapy. And they're also trying to find funds kasi during that time wala silang pera. So humihingi pa sila sa mga different regions na sana i-cover siya ng fund ng different regions, and we tried to find that way, no? So for example, the funding of the Cancer Assistance Fund and the MAIFIP is one way of, linking the different patients to different, services across the country. Then the other thing is, there was also a clamor to really increase the number of access sites across the country. Kasi before, there were just around 30. Ngayon, 34 na. By next year, it will be around 36. Kasi may nagdagdag na po tayo na 2 regions that has already, their own cancer access site that is fully supported by the Department of Health. So that is in Caraga and also in 4B. So that's Democrito Plaza, and Oriental Mindoro Provincial Hospital. And that leaves us with only one region that doesn't have a cancer access site, and that is Bangsamoro Autonomous Region. So medyo mahirap po, pero Bangsamoro is also trying to work, no, in terms of putting up their own access site. Pero putting up an access site is not enough. Kasi even though meron kang access site dyan, the services are not able or are not complete, no, to provide the needs of all the cancer patients. Kaya there is really a great need, no, for us to really create this kind of public-private partnership through MOAs and mga framework agreement with the different private sector for the different cancer services, PET scan, radiation therapy, brachytherapy, etc. Then, in the past 2 years, we've also seen, a push for cancer financing that is actually already starting to fuel that extra mile that we need. So kung makikita po nyo dito, I think I've seen the program, PhilHealth will be talking about the cancer outpatient benefit package. And this is a good start, no? Because PhilHealth in 2025 released their own outpatient screening benefit for breast, lung, liver, and colorectal. Kasi before, hindi po to bayad. So kung hindi bayad ang isang serbisyo, then it's a usual human behavior na you will not go or you will not avail it, di ba? So because of this, PhilHealth is actually trying to help us to change the behavior of the people that is directed towards early detection and prevention. And we're also trying to use the Cancer Assistance Fund to focus in terms of screening and early detection. Kasi before, the Cancer Assistance Fund that we give to the different access site, it was mainly used for diagnostics, for cancer treatment. Pero napag-isipan namin sa central office and with the different stakeholders, if we keep on putting the money in terms of treatment, maghahabulan na po tayo for treatment and lumalaki po yung gastos. In fact, the total needs, the total money that we need to cater of all yung mga na-register natin na patient will amount to around at least 20 billion pesos per year. Pero the only money that they're giving, that the Congress is giving is around 1.2 billion. So hindi talaga siya kakayanin. So the only way is to try to shift that kind of financing towards screening and early detection. So here you would see, no, in 2024, there are 16 access sites that are already providing screening, and this is funded by the Cancer Assistance Fund. And in 2025, tumaas po yan into 18 access site that is already providing free screening and early detection services. And I hope hindi ko po nakita dito yung Vicente Soto, pero I think this is also a good opportunity, no, to rally the people and also our different program managers to really push for that. Use the Cancer Assistance Fund to fund our screening and early detection. Kasi PhilHealth is only paying for breast, lung, liver, colorectal, but there are also other, cancer screening services that are not yet covered by PhilHealth, and CAF will be able to cover that. And we're also starting to decentralize cancer meds. Kasi before, the cancer medicine are procured by central office. So tumatagal po talaga yung pag-procure. And once we procure, pagdating po niya sa baba, hindi na po yan yung need nyo. Or probably, kulang na or nag-iba na ang mga kailangan ng mga gamot. So that ends in terms of rejection. So hahanapan naman namin ng mga ibang hospital na tumatanggap niyan. So we're starting already downloading funds to the different hospitals that we have, and yung hospital na po yung bibili. So with that, in that way, you will have that kind of control and more responsive, fiscal management to make sure na yung binibili nyong gamot are really akma doon sa pangangailangan ninyo. And for 2026, 73 million is downloaded to Vicente Soto to provide that kind of cancer medicines, procurement of cancer medicines for our different cancer patients. So ang next question dyan, paano naman yung mga non-PNF? Kasi we've seen already yung mga need, no, yung mga reseta ng mga doktor for non-PNF drug. And I've seen the policy of MAIFIP. MAIFIP has also mentioned there na they are also able to cover medicines registered in the FDA. So it's kind of a broad statement clause, no, that would that will kind of provide that kind of flexibility. And I think last week the pharmaceutical division has also issued their own administrative order to facilitate the inclusion of some of non-PNF drugs in the Philippine National Formulary. And I think there's a provision, kailangan ko pa siyang basahin kasi kaka-release lang po niya, na it kind of says na the government can access it for at least a period of 1 year while it's in the process of review in the inclusion in the PNF. So I think that gives us already the kind of leverage to have that immediate access for a short period of time for all those non-PNF drugs. So that's something that's a new policy that we have to also check, no, and also see how we can adopt it in our different cancer hospitals. Then we've seen also the need about data. When we talk about financing, the first thing that they will ask us is about data. And yun po yung reason bakit hindi rin po tayo makapag-push for more financing money, because when they ask us for data, we don't have that kind of robust data. So one way that we're trying to work right now is to really making sure that the local government units and even the private sector are helping us submit or get or gather their reports. So yung mga doktor, if there are some doctors here or societies, or yung mga medical societies, I know you are doing a lot of screening, a lot of patient consultations, etc. But at the end of the day, the patients that you're catering are also the patients that we're also targeting at a bigger scale. And we want to get that kind of information, how much or gaano na po kalaki yung mga naserbisyohan natin. Kasi that's the only way to provide the Congress that kind of information, this is the magnitude of the cancer patients across the country. So the hospital-based cancer registry is a very critical intervention also that we're trying to setting up with the help of the Philippine Cancer Center. And I hope, I'm not sure if Vicente Soto has already started to have a dialogue with Philippine Cancer Center to set up that hospital-based cancer registry. And what we want is to streamline the different cancer registries across the country to have that minimum data, variable data sets. And yun po yung aakyat sa Philippine Cancer Center, because that's the only way for us to gather all the reports. So I think that's the direction also the Philippine Cancer Center right now, to ensure that all the services, all the cancer census in the private and government facilities are being captured by the government. Then we are also working right now in terms of population-based cancer registry. So iba po tong population-based cancer registry with what we call the hospital-based cancer registry. The hospital-based cancer registry is just getting the information of the cancer patients in your hospital, and the data only holds true to your hospital. But when we talk about gaano na po kalaki ang cancer patients sa buong bansa, ano po yung proportion of breast, colorectal, lung, etc., yung mga mortality and morbidity in the entire country. It's not the hospital-based cancer registry that will only answer that, but it's what we call the population-based cancer registry. So this is a work between the hospitals and the local civil registrars to gather all of that data, and we're capturing it through a scientific method. So Vicente Soto is already, Vicente Soto is already one of our hospitals that we're trying to, expand right now to be part of our PBCR. Kasi later on, there will be some of the registrars that will be gathering data from Cebu, and that will be consolidated to get, generalized information to add up to the entire Philippines. So that's one way of getting the different information to have us a very strong, robust information in terms of cancer. Then here you would see also, we started also working with POGs to get also our screening information. So kung makikita po nyo, tumaas din po yung screening natin in terms of cervical cancer and breast. I think CHD, Ma'am Servil will present later on. But 2% of that, we get that kind of information. 2% of that is coming from the private sector. All the while, we thought ang liit lang sila. Pero kung makikita nyo, ang laki ng 2%. And hindi pa yan complete that they have submitted to us. So probably we can get more. Kasi when we look at the entire picture, ang baba po ng screening, but I don't think that's true kasi ang OB department, different OB departments of the different hospitals are doing outreach. And we want to understand what is the magnitude of the women that we still need to see. No? So that's with the help of our, reporting from the private sector. And later on, once we are able to perfect that, we're trying to build right now, we're still piloting this. This is what we call the Cancer Screening Registry. This is a national cancer screening registry. This is not just about getting the number of women na screen natin, pero this is about also sharing of information to the different facilities. So you get screened here in Vicente Soto or in an LGU in Cebu, and you can get treated in other facilities, and we capture you still as one person, and we can trace you where you are. So this is something now we're working, and we're trying to also to put that kind of feature na meron siyang patient navigation and nudging of the patient either through text or through call, telling you na, okay, it's time for you to come back. Kasi with the different services, mahirap po yung cancer screening. Kasi you screen a person in every 2 to 3 years, depende sa interval niya based on the on the latest recommendation. And 2 years without any touch point would already amount to at least 50% defaulters. Mawawala po yan, hindi na po yan babalik. 6 months nga lang, nakalimutan mo na magpapa-medical check-up ka, di ba? How much more kung 3 taon? So, with this kind of registry, we're trying to, get information to you directly. So, parang may text mechanism siya. So, this is a work with the ICT, pero we're trying to perfect it yet in Region 6 to pilot demonstrate it. And later on, we'll also start it here in Cebu, sa Bantayan Island, because we're also trying to provide funds for Bantayan Island for screening. Okay. Then, the most important thing also when we talk about cancer is also making sure that we're also trying to address the social determinants of health. Kasi cancer treatment is not just about, okay, I will just treat you. Pero access to treatment is also being impacted by family dynamics, okay? May mga bata po ba siya? Saan siya kukuha niyan? So mga prioritization, etc. So educated siya, etc. So these are the things, no? And that also hinders, for example, transportation, okay? Gusto nga niya din magpa-treat, pero ang layo. And wala akong pamasahin ng airplane papuntang Manila if I want to get PET scan. If I am a patient here in Cebu. Okay? So with that, we're trying also to help them or we're trying to link them in terms of putting financing. So babayaran po namin yan para makapunta po kayo dyan. So the CAF is also designed, the Cancer Assistance Fund is also designed to provide support for indirect cost. And indirect cost would mean halfway houses, transportation, etc. This is a very difficult intervention. Kasi especially when we talk about government funds and yung kalaban natin po dyan, yung Commission on Audit. Pero a lot of hospitals already right now are trying to work with the private sector. They are paying yung mga hotel, yung mga hostel na mga maliliit at saka yung mga boarding houses na mga sa palibot nila, and that's being free. Free siya, bayad po siya ng ng hospital natin. So when you get a radiation therapy, that you have to stay there in that facility for 1 month, you will be paid for that. Kasi I remember when I was also having my radiation treatment, 10 years ago, I'm also a cancer survivor. I'm a person diagnosed with lymphoma. We don't have a radiation therapy in Iloilo. I have to fly here in Cebu. And I don't know, Vicente Soto pa during the time, I was only referred to Perpetual Sucor. And we have to find a bahay sa palibot ng Perpetual Sucor for me to stay for 1 month for my radiation. So imagine the first thing that we came here is not for treatment, maghahanap pa kami ng bahay. So kung wala kaming kakayanan during that time, probably I would not go here. I would not go for Cebu. So I would just stay there in Iloilo and wait for my sentence, di ba? But so these are the things that we want also to address, the indirect cost that will help our patients to access the immediate care that they need. Then another thing that's also critically important is palliative care. I know medyo complicated tong palliative care, pero this is one way of making sure that the patients are actually focused in terms of their healing. Hindi na po sila nagfo-focus sa kung ano-anong problema. So we've been working with Jose Bilingad in Central Luzon. We've been providing them money for them to train our different palliative care specialists across the country. And right now, there are already 60 healthcare providers nationwide that are able to, provide specialist care for palliative care. And hindi lang po siya ito sa hospital. This is a training and an intervention of palliative care that is linked in the community. Meaning, pag cancer patient ka and when you go home, there will be a service provider that will catch for you, no? Or i-follow through ka in your community. So they are starting small in some of the regions kasi they could not really expand because there's a lot of requirements and there's a lot of infrastructure that's needed and a strong relationship with the local government unit to push for this. So we're starting small, pero there's already some of the regions that have been starting with palliative care. And in the Cancer Assistance Fund, probably in 2027, we'll also be including palliative care as part of the service package that will be paid by the Cancer Assistance Fund because this is important also. Okay. Then we're talking about human resource. I remember there was a cancer council that Dr. Rami Rojas presented the status of all the training hospitals in the country. And we've seen in his presentation, sinabi niya po doon na kulang ang mga doktor. Hindi lang sa doktor, pero mga specialista sa cancer na mga doktor. So for example, in gynae-onco, the ideal is around 300 plus gynae-oncologists in the country. What we have right now is only around 130. So that's nearly half. Same also with radiation oncologists. Very rare species yan sila. Kaya marami ding mga facilities that has the infrastructure to really put up radiation equipment and services, pero wala silang rad-onco. So hindi rin siya matutuloy, no? Hindi nahihirapan din sila maghanap. So that's one problem of human resource. So I know that's a big discussion and that's a very big work to do, pero we're starting also addressing the challenge in terms of human resource in primary care. So here you could see, the task shifting. I think there's a presentation later on for cervical cancer, and this is one good example that we're trying to start the task shifting for cancer services. Kasi before, when you talk about cervical cancer, the treatment for that, the precancerous lesion treatment was usually done before by either a trained gynae-onco or an OB specialist. But right now, we're trying to train midwives and nurses to treat that precancerous lesion in primary care. Meaning, they find it through either VIA, suka, or through HPV DNA. Pag positive niya, hindi na po siya pupuntahin doon sa Vicente Soto or sa pinakamalapit na Apex facility. In primary care, we treat them 1 minute with a battery-operated thermal ablation gun. And that is one thing that we're doing right now. And we're also providing thermal ablation machines to our primary care facilities to really make sure that they're doing it good. And also we're trying to pull human resource to train other regions. So this year, Ma'am Servil would agree that Region 7 is not yet trained for the new modules for cervical cancer treatment in the primary care, but NCR will be coming here in Cebu to help you. So this is one way we're doing namin. Ang ginagawa po namin, yung mga regions that has already the capacity, we deploy them in different regions to help other regions. So what Cebu has done for Caraga, then NCR will also do the same to Cebu. Then I think I've mentioned this and I've emphasized that in order for us to strategically address cancer, the only way is really start it through early detection. Hindi po talaga natin kakayanin if we put always all our intervention to treatment. So here you could see we've been already increasing the number of cervical cancer screenings that we have done in the past 2 years, including already breast. And this year, we're already starting working with the Philippine Society of Gastroenterology to pilot demonstrate the colorectal cancer screening in Bicol and Cordillera. So mahirap po pala siya ang colorectal cancer screening, all the while it's just easy. Kung titignan po namin, pinaka-easy pala na screening cervical, second would be followed by breast, and third would be colorectal. Kasi bakit? When you try to create a cancer screening program, you also have to think, ano ang service delivery pathway. So imagine the specimen for colorectal is a stool. So you could not just get stool anytime you want. Nasabi mo, pahingi ng stool mo. Hindi. Di ba? You will have to really ask the patient to get their stool and then ita-transport po yan. So imagine that's smelly, malaki, saan nila i-refrigerate. So mahirap po pala talaga siya i-implement. We thought it's just easy. Financing it is just easy, but implementing it is the hard part, for colorectal cancer screening. So we hope to get that success story from Cordillera in Bicol, and in the next 2 to 3 years, probably we'll be able to roll that out already as a national cancer screening program for colorectal cancer. And that's also, coupled with interventions to make sure technologies for that are also available. FIT, for example, the fecal immunochemical test is already, approved by the Health Technology Assessment, meaning government can already pay for that. Okay, so that's one thing that we're doing right now. And I think this is my last slide, no? And when we did the Cancer Forum in 2020, last year in Iloilo, we're also doing this thing that that you are doing, no? But this is a national cancer forum, so all of the cancer hospitals are in one place, sit together and present their accomplishments and the stories of their success, etc. And we learned a lot from them. And it was only in 2025 Cancer Forum that we have seen how hospitals and communities are actually finding creative and compassionate ways to remove barriers in cancer care. And ang dami po naming na-learn from them. We've seen the therapeutic playroom from Cotabato Regional Medical Center in Mindanao for their pediatric oncology. And it changes really a lot, no? Yung experience ng isang bata and yung pamilya when they undergo and complete their cancer treatment. Then we also have this Balay Paglaom from Bicol Regional Hospital and Medical Center. So this is the halfway house that they created, no? And that halfway house is not just only a house, no, not that you will stay there and mag-antay ka ng treatment mo, but it has other holistic cancer services inside to cater not only to the patient but also for the family. So they call that Balay Paglaom. Then we also have seen stories of Cart of Joy. This is what they call the ambulatory chemotherapy emotional support, created and innovated by the Dr. Paulino Garcia Memorial Research and Medical Center. And lastly, yung Bangsamoro, kasi very iba talaga syempre yung Bangsamoro because of the differences in faith. So they have a faith-sensitive and hospice-inclusive care models. Kasi people in Bangsamoro going to the Bangsamoro Regional Hospital are not just only Muslims, but meron din mga Kristiyano po doon. So they've tried to create this kind of faith-sensitive hospice and inclusive care models. So I think I will end my slide na in the next coming years, we really need to push our collective efforts together and our interventions as one. Pero we have to remember this, that in order for us to succeed, cancer care becomes truly effective when it goes beyond treatment. So it's not just within the hospital walls, it's not just within the wards, but it has to go beyond treatment. So treatment for family, for their communities as well. So with that, maraming salamat po, and we look forward to learning a lot of lessons from the next presenters and also from this forum. Thank you very much po, and good luck.
Thank you so much, Sir Vince. And indeed, cancer care becomes more personal when you yourself had survived it, right? And I think Sir Vince has really standing here in front today, speaking his truth and directing us on cancer care. So to give the award, the certificate rather, may call on Dr. Baton to give the certificate together with Miss Gyogyo. A big round of applause, please. And may we call on Sir Vince to please come on stage. To read the citation and the certificate, Certificate of Appreciation is awarded to Mr. Vincent Sumergido in recognition of his efforts, expertise, and commitment ensuring the success of this event during the 2nd Regional Cancer Summit on March 5 to 6, 2026 at the Sarrosa International Hotel and Residential Suites. Signed, Joshua G. Brillantes, MD, MPH, CESO 4, Director 4. And also, may we invite on stage Dr. Reynat Legaray, please. And Dr. Galbo as well.
Okay, thank you so much again. Thank you, Mr. Vincent Sumargido. To discuss the status of cancer program in the region, let's welcome the Nurse 3 of the DOH CVCHD, Ms. Servomay V. Villespin. A round of applause, please.
Maayong buntag sa tanan. Okay pa mo diha? Okay. So once again, good morning. And thank you for joining the second Regional Cancer Summit. So today I will be sharing the status of the cancer program here in Central Visayas, our current progress, challenges, and the direction we're taking towards stronger cancer control. Okay. So as we continue to advance the healthcare in the Philippines, Secretary Sarrosa has outlined 8 priority programs designed to address the nation's pressing health challenges. So from immunization to cancer control, this program aims to enhance overall health outcomes, reduce the health disparities, and pave the way for a healthier, more resilient for all Filipinos. So ganina, it was mentioned by Sir Vince, the Republic Act number 11225, also known as the National Cancer Integrated, the National Integrated Cancer Control Act. No, it was signed into law last February 14, 2019. So it marks a critical step forward in the Philippines' fights against cancer. It establishes national framework focused on prevention, early detection, comprehensive treatment, and patient care, ensuring that every Filipino has access to quality cancer services regardless of their circumstances. So a key part of the law is the creation of the National Cancer Control Council, which will oversee the country's cancer programs and help in shaping the country's multi-sectoral approach in fighting cancer. So we have placed a great importance in improving governance systems for cancer. So the Central Visayas, we created the Regional Integrated Cancer Control Committee composed of different national government agencies, Department of Health retained hospitals, cities, municipalities, provincial health offices, and the NGOs, partners that share the same vision. So this is our picture from the first and the second RICC, the first quarter and the last quarter meeting. So we really wanted to have a quarterly meeting for the RRCC. So expected, partners will be sending again letters this month. This coming March 31, we'll be having our first quarter RICC meeting. Excited na ba mo? Ko excited na, char. Ito. So the Cancer Control Unit, which is under by the Non-Communicable Disease Section, handles the Regional Integrated Cancer Control Committee and serve as the framework for all the cancer-related activities in Central Visayas and serve as the Secretariat of the RICC. On the other hand, the Philippine Cancer Center oversees the network of cancer care facility, Center of Excellence in Cancer Care, Research and Development and Capacity Development, primary repository of all cancer registries, and permanent resource person in NICCC. So we have one national specialty facility, which is located in the National Capital Region, the Philippine Cancer Center. We have 11 advanced comprehensive facilities. And sa Central Visayas, we have the Vicente Soto Memorial Medical Center. And we have 13 basic comprehensive facilities. So the Department of Health, we are guided by the 1970-90 strategy launched by the World Health Organization, which is a global roadmap of eliminating the cervical cancer as a public health threat by 2030, and it sets 3 key targets. So atong 3 key targets, the 90-70-90. So when we say 90% of girls fully vaccinated sa HPV vaccine by the age of 15. And 70% of women are screened with high-performance test by 35 years of age, and 90% of women identified with cervical disease receive the treatment. So achieving these targets can reduce more than 40% of new cervical cancer cases and prevent 5 million related deaths by 2050. So this comprehensive approach addresses prevention, early detection, and treatment, making it a critical step towards global health equity and women's health empowerment. While the Philippines have implemented a quite number of interventions using this strategy, and clearly still a lot has to be done. So when I was assigned as a program manager of the cancer control, kanang dito jud ako nakita ang kalisod, sa labi na sa mga bata nga adunay cancer. And it really struck my heart, and I said, for the 12 years that I've been here in DOH, really this program is my calling. So I will give it my all. So I cannot do it alone, DOH cannot do it alone. We need to help each other. Okay. So cancer prevention has been placed at the core of the strategic operations. We have 6,274 grade 4 students given the HPV vaccine, and 2,000, that's the HPV 1, and 2,412 grade 4 students given HPV 2 vaccine, and the total of, we have 83,366 Hep B vaccine given within the 24 hours after birth. So, ari na to makita ang challenge. Our target was 70% of students or girls aged 15 will be vaccinated with HPV. But sadly, this year, 2025, for the HPV-1, we only reached the 10.33%, for the vaccination, and 3.92% for the HPV-2 vaccination. So this is really a great challenge for everybody, Okay, as we all know, cervical cancer, if it is ganang na vaccinated or early detected, ma-prevent ra gyud nato ang cervical cancer. So, as you can see, from this slide, the cervical cancer mortality rate from the year 2024, there is an increasing number of deaths for cervical cancer. So miski gagmay or point something lang na siya, but still, there is an increasing number. Sa na-recorded lang ni, wala pa nilabot, so wala na record. Okay. So inclusion of mass intervention to drive wider reach for cancer screening. This year, naningkamot jud ta, The Central, the Region 7 really do our best in doing the screening, for the cervical cancer. So last August, I think, we only have 1,807 cervical screening, but now we've reached 15,227 women screened for cervical cancer. Pagpaksad mo mga higala, Kay pagpawa sa kulba din sa tubangan ba, And then, before, from bottom to, we ranked Nagkatawa si Sir Vince, no? We ranked, among all the 18 regions, we ranked at the top 10, no, in cervical screening. So they provided us a 6 million budget, but when they see sa ato ang accomplishment, ang central office gitagaan gidayon tag 11 million. That's for the procurement of the HPV DNA kits, no? Ato nang ihatod sa inyong sa tagsa ka mga LGUs, labining ng mga LGUs diri nga mga performing. So mag HPV DNA screening na ta dito sa inyo ang LGUs. Okay. So mao ni makalipay kay ni siya. Hopefully mas musaka pa ta this year. Having already the HPV DNA, why not, diba? Okay. So for the breast cancer screening, this is a quite challenge, no? For sa Bohol province, we only have 62 rakabuok ang ato ang na-screen. But for the Cebu province, we have 20,931. This is from the FHSIS, no? Ato ang source ani. And now, since ang Cebu province, we have partners, no, for the cancer program. We have RAFI, we have WOMB, we have POGS, we have a lot of partners. Then in Bohol, we're having a plan to have a MOA with IMAP as our partner for the screening. So nindot na pod, no, nana po yung makatutok pod ni Bohol together with IMAP sa ato ang mga cervical cancer screening and breast cancer screening. So streamlined health promotion in different settings to accelerate social behavior change. So mao jud ni ang atoang mga challenges nga naatong na-encounter sa LGUs, no, ang behavior sa mga tao una magpa-screen sa cancer, not just only cervical but in general sa cancer, no, dili sa mo adto. It's because there are a lot of factors nga nung dili sila mo duol sa ato ang mga health centers. So that's why we intensified our advocacies through media cards, no, cancer events. Ato ning kani today we are live. Am I right, Ma'am Jov? No, we are live right now. No, sa makita po ni sa ato ang mga friends, no, sa Facebook nga we have this kanang kind of activity for cancer. So expanded access to cancer medicines and critical treatment support. We have the Cancer Assistance Funds, no, as mentioned ni Sir Vince Ganiha, no. It caters the diagnostics and laboratory services, therapeutic procedures, augmentation of cancer medicines, prevention, screening, diagnostic, other support services, or the indirect costs. So most of the problem of our patients in cancer are the indirect costs. So what are these indirect costs? Kanang ilang mga pliti-pliti, no? Padong sa soto, padong sa perpetual, ilang kastayhan, ilang pagkaon, inana. So we're looking into how to help this or pwede ba nato ma-adapt ang katong mga best practices that shown ni Sir Vince ganina, no? With the help of our partners. No, since 2022, we have 102,863 cancer patients avail the CAF. No, this is nationwide, and 34 CAF access sites nationwide, and every patient or every beneficiary are provided or allocated 180,000 pesos per patient. 150 pa? Oh, di ba? Sige, 150 di ay nasa iyo. So 150,000 pesos per beneficiary per year, no? Ang ato ang patient. So sa Central Visayas, this is our accomplishment, no? Sa Vicente Soto. For the CSP map, this is only for January and September. We have 2,023 patients who availed the CSP map for the medicines. And for the Cancer Assistance Fund, we have 29,428 patients nga naka-avail or naka-benefit sa ato ang CAF. Okay, so the Central Visayas CSP map and CAF site, we only have Vicente Soto Memorial Medical Center as of the moment. No, si Soto pa jud, and we all know that Soto is not only catering patients from Cebu province, but also catering patients from other island nga mga provinces, no? Maabot diri ang taga Asaman, taga Leyte, taga Negros, and ang uban gani napadyoy from layo na maabot pag yun dinhi sa ato sa Vicente Soto. That's why last year we have our monitoring together with central office, no, that the Governor Celestino Galliares Memorial Hospital will be a CSP map and CAF site soon. So, ito tagas masipang pakpak ang Galliares, no? So, one of our purpose in this is we were going to decongest pod Soto so that our patients from Bohol adto na lang sila sa Galliares. So dili na sad sila mogasto og pliti pa sa ocean jet, no? And dili pa sila mogasto og pagkaon diri. So adto na lang sila sa ilaang tungod. No, we're bringing the services gadto jud sa ilaang tungdanan sa ato ang mga pasyente. So as mentioned by Sir Vince, possibly, no? 100% with possibility, Sir Vince, that next year, 2027, mahimo na jud og CSP MAF and CAF site ang Governor Celestino Galliares Memorial Hospital. Because as of the moment, napa na siya sa concurrence of the National Integrated Cancer Control Council. So, aside from that, improve the health system infrastructures for quality cancer care. So not just kanang atong mga advocacy and also, syempre, no, ang atong mga patients, we wanted to give them a very nice environment nga moadto sila sa hospital nga dili na sila magnilinyahay o unsa pa, or bati ang bench, bati ang nurses station. But now in our I am very proud to say, no, sa atong cancer center diri sa Soto, it's very nice na jud kaayo mao ni ato ang new cancer center sa Vicente Soto Memorial Medical Center. So, at this moment, I'd like to share some photos of our first quarter of 2026 and major achievements of 2025. So, this was conducted last year. We had our 2 batch of CST, or the Clinical Skills Training in Cervical and Breast Cancer Screening for Service Providers. We trained 30 in total nga mga service providers. Then, we had our 2 RICC, as I mentioned ganina. And then, so our CSTDI, it is with partnership with Rafi and POGS and also HPFS. So, this year, we launched our Cancer Awareness Month last February 4 at Vicente Soto with a theme United by Unique, no, together with PhilHealth, SOTA, and DOH. And also we have the Kapihan sa PIA. And lastly, one of our major achievements or accomplishment this first quarter is the National Cancer Awareness Culmination Fun Run in the municipality of Taboylan. So despite of all these significant milestones, more work has yet to be done to fulfill the National Integrated Cancer Control Act. So daghan pa kaitag buluhaton. So first is intensify cancer screening and early detection programs to combat cancer strategically. Ako pa gibutang diri, even though we already have 2 batches gonna trained. Ang training, it's because sa pagkuha nato sa census, no, most of our new patients, new MHOs, are not trained with clinical skills, cervical cancer and breast cancer screening. Kay ubay-ubay na ang ato ang mga nang-retire nga mga PHN, unya og mga MHO, so daghan na jud ang wala pa na train. So this is quite a challenge. For this year, we'll be having a series of trainings, but only, I think, 6 batches for Cebu and Bohol. And then, second, procurement of thermal ablation machines. Nahuman ako ni ang slide, but then nahatagan taog thermal ablation. We already have 3 thermal ablation from central office, donated by HPFS, right? And our thermal ablation, 1 thermal ablation, adto nato mabutang sa municipality of Bantayan. And para ang atong mga taga-Bantayan, dili na mo labang if there is nasin nato nga mga precancerous lesions. And next is the other thermal ablation, ato nang ibutang sa Bohol, possibly yun na mabutang sa Galliares. And ang usa ari sa Cebu, no? Kanang nagwonder mo, hala, usa ra ka buok, dako kay ang Cebu province. Kanang nanay trick diha gamay, no? Kay mga tagpasalamat daan ni Ma'am Barbie, no? Kay the PHO, no, sa Cebu Provincial Health Office will procure for thermal ablation, no, to be put sa ato ang mga CPH. Oh. And then kaning atong thermal ablation nga naa diri sa DOH, we will put it in our wellness clinic, no? Katong sa dili makaadto or sa ato ang mga partners or naa diri nga moadto ra pod sa atong wellness clinic. Oh, okay ra mo ana. Isn't that a good news? Good news kaayo. Next is ultrasound in Bukas, strong healthcare provider networks, relationship of Bukas with Purok Kalusugan, specialty centers, and improve the patient journey through comprehensive and timely patient navigation. So this one is really our great challenge, no, ang patient navigation. Why? Most of our patients, mamamatay lang, it's because of the loss to follow up. So that's why this year we'll be having a community-based patient navigation workshop, no, together with Soto, no, kay para pod atong magiyahan ang ato ang mga pasyente ug atong mga ma-follow up ang atong pasyente sa ilang treatment ug asa na pod sila, no, kay mostly nagpa-check, nagpa-biopsy kahuman mo adto na lang kay mo claim sa or mo kuha sa mo process sa death certificate ana na dayon. So atong paningkamutan no nga atong mahatag yun ang care sa mga patients nato nga suffering from cancer. Then setting up and strengthening cancer registries to inform national directions, improve support, value of cancer health financing will drive the entire health system's behavior to more responsive, such as budget appropriation from local government units. So why local government units? We really wanted nga in order to solve the health issue, the pressing health issues in our society, we really need the help of our leaders, no, our local chief executives. No, kay they will be the one to take the leap, or they are the leaders, no, nga mo support gyud ani sa ato ang mga programa. Kay kung ang atong mga programa wala tay ngipon or wala tay policies, walay padulngan. So ang ato ang mayors and ato ang mga leaders from the LGUs, we really badly need their help, no, para sa ato ang mga patients, not just for cancer. Why? Because there are a lot of social determinants of health that affects the health sa ato ang mga katawhan, no? Daghang kaayong factors. That's why we really need to put policies, we really need to put budget, not dili necessary dako kaayo, but as long as there is dako na kaay ng tabang labi na sa atong mga patient nga nagsuffer sa cancer. Kay cancer dili baratuhon nga sakit. Diba? Diha ako na shock when I have we did our monitoring. Pagkahibaw na ko ang trastuzumab ba na, doc? Sakto ko, no? It costs, one vial costs 100,000. Sakto ba? No? Na 50 something like inana nga pagtan-aw namon ko hala lisod jud ay ma-cancer. So that's why we really need the help of these NGOs, stakeholders, partners, and also our leaders. Next is stable access of cancer medicines and therapies, access to PNF, non-PNF medicines, to special access schemes, access to pain medication, and lastly, the localization of the NICALO at the local government unit level and institutionalization of the cancer control program for sustainability. So with that, lastly, with a unified approach, we're turning the tide against cancer in Central Visayas. Let's beat the cancer and save more lives, because cancer can't, but we can. Thank you, and once again, good morning.
Thank you so much, Ma'am Serville. Again, cancer can't, but we can. All right? So to continue, I know some of you are actually asking about this very trending program right now from DOH. We have the Yakap, right? And so to give us an overview as to what PhilHealth Yaka program is. Please help me welcome the representative from PhilHealth Region 7. She is a medical specialist from the Benefits Administration section of the PhilHealth Regional Office 7, Dr. Avril H. Chu. A big round of applause, please.
All right, thank you. Good morning, everyone. Yes, so I just looked at the program this morning, and I think I saw that the time slot was 10 minutes. So I will make my presentation as concise and as short as possible to make sure masud ko sa 10 minutes nga time. All right, so that di sad kay ta masigno kanang malaaya na mo dire that I'm in front. But anyway, I'll try to make my presentation very interesting, especially for this day's activity. All right, so before I begin, I would like to thank DOH and I think Rafi for having us here and for a very successful activity. So thank you very much. Sorry. All right. So my presentation will just be a part of YAKAP because before I begin YAKAP, the benefits under the umbrella of YAKAP will include consultation, laboratories or diagnostics, medications, and of course, cancer screening. So since this morning's activity is about cancer screening, I will be talking about the selected outpatient cancer screening test. So this program in PhilHealth actually began on August 14 of 2025. So it's relatively new. So because if you remember, si PhilHealth, we really did not have any benefits for diagnostics. But now, we're gearing towards a more proactive approach wherein we want to catch the patient prior to hospitalization so that the cost of healthcare will also be reduced. I think that's really the goal here. So we're taking a more proactive approach now. So as a background, so we have the Universal Healthcare Act, which mandates PhilHealth to increase coverage for outpatient services for preventive and basic care without needing to go to the hospital. So this is where our YAKAP program comes in. Also, we have the NICA Act, so wherein they mandated PhilHealth to expand the benefit packages for cancer. And of course, what you see on screen is Consulta. That is the old term. So now we have relaunched and rebranded Consulta as YAKAP, or Yaman ng Kalusugan Program. All right? So cancer is the third leading cause of death in the Philippines, among which the very common ones are breast, lung, colorectal, liver, and prostate. So that's why when we created the screening test, we had this in mind, the most common cancer in the Philippines. Currently, PhilHealth, we already have an enhanced Z-benefit program for breast cancer. So initially, when this program, the Z-benefit program, was launched in 2012, breast cancer was already a part of it. However, our package then was just 100,000. And this 100,000 should cover the entire cost of treatment. So moving forward I think it was back in 2024, that we have enhanced our benefit for breast cancer. It is now up to 1.4 million pesos. But of course, the 1.4 million is not a one-time benefit package that we give out to our beneficiaries. So this is if the entire treatment was availed of by the patient. Because I remembered before, when we had this benefit package, we only accept up to stage 3A breast cancer without medications or without treatment. So technically, for those patients who were already diagnosed, who already underwent chemotherapy, they were not able to avail of our Z benefits program. But when we enhanced the package in 2024, we now cover all stages of breast cancer. Even if the patient has undergone, let's just say, chemotherapy in one private facility. But unfortunately, after several sessions, the patient was financially drained. So then they then moved to a government facility, which is a Z benefit provider. Pwede na siya karon. So in ana na kanais ang ato ang benefit for breast cancer. Of course, it will start with 1 or 2 benefit packages lang sa. Dili na to kaya to enhance everything. But slowly, that's the direction also of our Z benefits program team to eventually enhance our Z benefit program packages. And mostly it's for cancer. All right? And then currently, we have ongoing development for lung cancer, liver, and prostate cancer. And also, we are trying to enhance our benefit package for colorectal cancer. All right, so the objective of this policy is to provide our beneficiaries with enhanced access to select cancer screening in outpatient setting. So for our scope, all qualified Filipino members, together with their beneficiaries, can avail of this benefit package as long as they are registered in a primary health care provider or a YACAP provider. So that's the first thing that they should do. So for all of us here, I would like to believe that we are all PhilHealth members. Am I right? Yes. All right. My next question is, are you all YACAP enrolled members? Or did you register to YACAP? I see a few in front, say, with a big yes, si Doc Baton. How about the people at the back? Have you registered? Yes? All right. So thank you very much. So registration to YACAP is free. So there's no added premium payment for this. So why not, for those who are not yet registered, you should maximize the benefit. Because technically, we're already paying for our premium contributions in PhilHealth. So we might as well maximize the benefits because, again, right now I'm just focusing on cancer screening, but segue gamay. Again, as I've mentioned earlier, YACAP also provides medications, other basic laboratories, if and when needed. So the gamot, actually, our coverage for gamot is 20,000 pesos per year per registered member. So meaning, if you're a family of 5, the only one working is, let's just say, the father. The father pays for the premium contribution. He has 4 dependents, the wife, housewife, so not working, and then they have 3 kids below 21 years old. So they are the qualified dependents of that member. So all 5 members can be registered to YACAP, and all 5 members get a separate 20,000 each per year for our gamot. Okay, so it's like that. So it's free. Let's maximize the benefit of PhilHealth. All right? So going back to my presentation, so the services covered again is selected cancer screening in an outpatient setting. So the providers are PhilHealth accredited providers as long as they obtain their license from DOH to operate such laboratory diagnostics. So the types of cancer screening covered, we have for breast cancer, lung cancer, colorectal cancer, and liver cancer. So for breast cancer, we cover mammography and breast ultrasound. For lung cancer, we have the low-dose chest CT scan. Colorectal cancer, we have colonoscopy. Liver cancer, we have liver ultrasound and alpha-fetoprotein. So again, for our qualified and registered members, no? So what they need to do is that they should go to a YACAP provider. So the YACAP provider will now do the physical examination, and if and when needed, that's when they give you the prescription for the diagnostic test. However, we also know that majority of us, we are first or initially diagnosed by our private physicians. So in that case, if it's a first time, you can bring the request coming from your private physician. You have to bring it to a YACAP provider so that the YACAP doctors can give you the prescription. And because the prescription that is being accepted by our cancer screening facilities should come from the YACAP. So, mura siya connected tanan, you just have to go to a YACAP provider first, and then they will give you the necessary request as needed. So here are the indications for the following test. So for mammogram and breast ultrasound, the profile should be a female, aged 50 to 69 years old for all cases. However, for those with risk factors, aged 40 to 49, pwede na siya. So the frequency, this should be done every 2 years for individuals aged 40 to 49, or every year starting 50 years old. For low-dose chest CT, the profile should be 50 years old and above with risk factors such as smoking and a family history of lung cancer. The frequency, this should be done yearly. For colonoscopy, 50 years old and above with risk factors like a family history or underlying conditions like inflammatory bowel disorders. And of course, if they have no risk factors, if their FIT or FOBT test results turn out to be positive, then they can have this test. The frequency is every 10 years. For alpha-fetoprotein and liver ultrasound, if you have the risk factors like hepatitis B or C, heavy and prolonged alcohol consumption, cirrhosis, diabetes, non-alcoholic fatty liver disease, or inherited metabolic disease, the frequency of this test is every 6 months. All right, so these are the indications for the cancer screening test under PhilHealth. So again, the provider should be DOH licensed and of course, PhilHealth accredited. So currently, because this was recently launched, I think in 2025. So for now, we have a few facilities, but actually, we are encouraging more facilities to be PhilHealth accredited for the cancer screening. So for now, I can name a few. We have, of course, Vicente Soto. We have Eversley. We have UC Med as a private facility. And actually, we have a lot more. You can see that in our website. But for now, these are the facilities that I can cite to you. So how do we engage the providers? Just in case, we have providers here who are not yet PhilHealth accredited for cancer screening. So what you need to do is you need to submit a letter of undertaking to PhilHealth. And mind you, once you have your facilities accredited, there is no accreditation fee. PhilHealth approves for them to be accredited for cancer screening facilities and then facilitates for their renewal of their accreditation. So if you can see on your screen, the cancer screening rates. So for mammogram, it's 2,610. For breast ultrasound, it's 1,350. Liver ultrasound is 960 and 80 cents. Alpha-fetoprotein is 1,230. Low-dose chest CT is 7,220. Colonoscopy is 24,670. So may I ask, for government facilities. Do you think that this rate is enough or kulang? Silence would mean yes, it's enough, or no, it's kulang. What do you think? So, but I believe, no, when this policy was crafted and when we came up with these amounts, it was always, no, in consultation with the different societies. And of course, we do not just make figures by saying, oh, this is the figure that we want to give out. So it's not like that. It's always in consultation with the different societies when we create this figure. So I believe for now, this is enough, but maybe in a few months' time, with the events going on, so I think inflation will sink in, or inflation will go higher. So maybe in a few months' time, makaingon ta, uy, nisaka man ang ato ang mga laboratory rates because everything will increase, no, with what's going on in the Middle East. So maybe then we can revisit also, and we can also make necessary changes to our current costing. Okay? So again, for all the accredited healthcare providers, they should follow the current standards of care and other PhilHealth or DOH-issued patient care standards. So again, to avail of your benefit, you need to go to a primary care provider. The primary care provider will assess and do consults and make the necessary request as needed. And then they will now refer you to a accredited cancer screening facility who performs the diagnostic test. And the cancer screening facility refers you back to the primary care provider or the YACAP provider. So this is just to show you how the cancer screening test request form looks like. All right? So this is the pathway for cancer screening. I've discussed this earlier, but you can take a photo of this one. And then, of course, for claims filing, just with any other claims benefit that you file for PhilHealth, it should be submitted through electronic filing. All right? So, of course, you need to attach the request form, your test result, and your claim signature form. So I think this is my last two slides. I will not mention our monitoring and evaluation, but we do monitoring and evaluation of all our accredited facilities. And with that, thank you very much, and good morning, everyone. So I hope nasud ko sa akong 10 minutes. Yes, thank you, everyone.
Okay, thank you so much, Dr. Alfred Chu, for the presentation of the PhilHealth YACA program. Okay, may I remind everyone to please scan the QR code at your respective table to access the program presentation and the evaluation of this activity. Okay, moving forward. For discussion of cancer program updates of Governor Celestino Galeares Memorial Medical Center, let's welcome Nurse 3, Ms. Carmel Therese T. Lopez. A round of applause, please.
Hello. Good morning, everyone. Before I start with just my very short presentation, please allow me to introduce myself. I am Carmel Therese Lopez. I am the Assistant Nurse Manager of the Oncology Services, Chemotherapy, and Hematology Unit of Governor Celestino Galeares Memorial Medical Center in Tagbilaran City, Bohol. So I'll just be sharing to you a little update of our baby chemotherapy unit. So for our cancer program initiatives, For the information of everyone, GCGMMC has applied for the Z benefit package for breast, prostate, and cervical cancer. However, we have not yet implemented this one due to our lack of the radiation oncologist, which Sir Vincent has mentioned earlier. So that's pending for now. As of the moment, we are still looking for someone who can work with our institution. Another would be if granted the CSP map and the Cancer Assistance Fund, we would want to provide our patients shelter and the transportation for us to travel to the institution, considering that other patients are actually still from the island or from the remote towns in Bohol. And yearly, we conduct a lay forum, usually on the third or the fourth quarter of the year. We conduct lay forum for us to be able to strengthen the early detection and prevention of cancer cases. We'd like to share our, this we call our best practices, because in our unit, it's really just a small area. Though our census for a year is way too little compared to that of Soto. We only have still around 2,000 plus chemotherapy sessions conducted in a year. But our unit is really small, so what we do is that we cohort our patients per day. So like for medical oncology patients, we cater to them on a Monday to a Wednesday, and then for gynae patients, we have them on Thursdays and Fridays so that we can accommodate all our patients considering the very limited space. And yes, we schedule our patients so that we could accommodate all of them. So this is how our unit looks like. So it's really, really small. And we do annual patient empowerment annually. So this patient empowerment is our way of gathering our patients. We do this on every December. This is to gather our patients, and then it's like a kind of a Christmas party for all of them. So we invite them, the patients, and one of their significant others. So, and we have seen also the effect of this. Nindot magud siya because they get to, ang mga patients magud, if they're scheduled, for example, that's every 3 weeks ilang schedule. So, bali mo dispatch ang more or less magkaabot sa schedule. But if not, so murag stranger man sila to each other. And we have seen that nindot siya nga practice because makaila-ila sila, they get to share experience, and ma-recognize po itong mga nahuman na para katong mga are still starting their treatment, ma-encourage po sila nga, ma-empower sila to continue with their treatment. So, mo ni siya nga mong patient empowerment. We just do it in our auditorium. And we just prepare a little program for them, games, and then meal, ana lang. And because, as I have mentioned earlier, there are still places in Bohol nga walay signal, napa sila sa island, so they will have to travel by boat pa or pila ka hours away ilang town from the hospital. So for their convenience, for example, kung na sila concerned, so we have created, with the advent of technology, so we have created the simple group chat lang sa Messenger so that whatever concerns they have, they can channel it to us directly o ma-address po ng ilang mga pangutana. Because dako po siya nga help para sa mga patient nga ilang mga anxiety ma-address po nato. So for our plans for 2026, so the patient empowerment will still be there because we do it annually man, and then hopefully we can acquire more equipment for the unit. But kung ano man po siya it's mostly infusion pumps, nga na lang. And then we also, because ang among unit is only for the outpatient cases, so for the inpatient, they're admitted in isa lang ka-ward. I mean, in the medical ward, they're just being allocated like 4 rooms. So, and only the nurses in the chemo unit ang trained. So we plan to do cross-training. For example, the nurse at the medical ward will be trained or ato sila mo report sa chemo unit para somehow ma-extend ang among training nila para sila pod knowledgeable enough to do chemotherapy in their areas. And hopefully this year, the rest of the nurses can apply for the nurse certification program of the DOH for hematology and oncology nursing. So that would be all. Thank you.
Thank you so much, ma'am. And moving forward, we will now talk about the myths and facts of chemotherapy and radiation. So to talk about this, please help me welcome our medical specialist from Vicente Soto Memorial Medical Center, Dr. Jamila Marie De Vera. A big round of applause, please.
Good morning. Don't worry, my lecture will be very short and sweet. Please project my slides. Ayan. From the title slide pa lang, sir. Okay. From the title of my slide, you can expect a very simple and easy to understand lecture because we have a diverse audience here in this Cancer Summit. We have patient advocates up to medical specialists. So we are all healthcare workers here, or at least involved in some way or another to healthcare. And as such, we are gatekeepers against medical misinformation. So we should already know what is myth, what is fact, what is true, and what is false about cancer treatment. So just a disclaimer, I am a medical oncologist, but I have been tasked to also talk about radiation therapy to just keep it short. And anyway, these are common questions we get asked by our cancer patients. So I hope my fellow oncologists in the audience don't get bored with my slides and instead find a common ground in these FAQs, mga frequently asked questions. We get to counter-check what we know. So chemotherapy always makes you lose all your hair. Myth or fact? Can I hear the audience to wake you up? Myth or fact? Dapat resounding? Myth. Okay. So, sa Binisaya pa, dili ta ng chemo, makaupaw. Just like, dili ta ng upaw, na upaw tungod sa chemo. So, ayaw tanaw sa Dr. Galbo, ha? Joke lang, Doc. Dr. Galbo is in solidarity with our cancer patients. Okay, so fact, not all chemo drugs cause hair loss because even this alone is a deterrent to patients. Di ba? Pag hadlok na gani ka maingnan na kay cancer because automatic mag-think ka, mag-chemo ko. Dok, di ko ganan mag-chemo kay maupaw ko. Okay? Even as medical oncologists, we are not immune to getting cancer. In fact, we have this superstition as doctors, kung unsa imong specialty, actually maupo na imong cause of death. No? So kung cardio ka, imong ikamatay, heart attack. Kung neurologist ka, stroke. Kung cancer doctor ka, o basin magka-cancer ka later on. So actually I remember a colleague, a medical oncologist, who she herself had breast cancer. No? And of course, she had to undergo chemotherapy. During that period that she was undergoing treatment, she hid from her colleagues. Because unsa man ang assumption kung upaw ka, di ba? Kalit ka na upaw. Dili ka na ginang long-standing upaw nga na explanation. Okay? Kalit ka na upaw. So, hala, nana siya cancer, kaya nag-chemo na siya, mo na siya na upaw siya. Okay? So, unsa man ang connotation na. Unsa may laing tambal di ay upaw, di ba? Automatic, what comes to mind, nag-chemo na siya. So, nana siya cancer. So, she is somewhat dying, no? Or at risk of death. Will she be able to do her job? Is she still competent? We still rely on her to be here 10 years down the road? Inana ba? So deterrent. So not all chemo drugs cause hair loss. Some drugs, though, of course, can cause hair loss. Commonly, ang mga breast cancer drugs na to, hair loss, yun iyang side effect. But many do not. Okay? So, colon cancer patients, di ka makakita upaw na sila, or even the head and neck cancer patients. So, some only cause hair thinning. Okay? So, kanang gamay lang kuan. Kana, pagka nipis sa buhok. Okay? And chemo-induced hair loss is temporary and usually regrows after treatment ends. Okay? So, mubalik ra na siya. Okay, another common question. Chemotherapy permanently affects the good cells. Myth or fact? Oh, asa naman tong resounding answer sa audience? Myth or fact? Myth, because the keyword here is permanently. Okay, kay mo maning pangutana sa patients, Dok, kanang chemo, maigo man daw atong good cells, ana. Diba? Oh, but, so true, it can affect the good cells, but not permanently. Okay, so we can read here, the body is made up of cells that normally divide and grow and are replaced. Okay, but cancer cells also divide and replicate. Okay, so maigo apil ang mga good cells nga paspas sad mo divide. Okay, chemotherapy is designed to target rapidly dividing cancer cells, and so it can also affect the healthy cells that divide rapidly, but not permanently ang side effect. Okay, so dili sa nato ilaro nga dili man good na maka-affect sa good cells, nya ika-CBC sa repeat cycles like anemia, nag-thrombocytopenia, nag-leukopenia. So you have to appraise them properly, no? Nga mobalik na sa normal eventually. So while chemo lowers white blood cell counts, this is temporary. The immune system typically begins recovering soon after treatment ends, okay? And then, next, chemotherapy is painful. So naiuban, hadlok, magpa-dextrose kay dok, sakit na siyang chemo. No? So when patients ask you questions, there is no stupid question. You need to validate their fears and concerns because sometimes that's the only inhibiting factor from them seeking treatment that they need. Okay, so myth. While the thought of chemo can be intimidating, kinsay di ma-intimidate og chemo. Even doctors, hadlok sad magpa-screening. Kay hadlok unsay makitaan, kay hadlok sad sa kailangan i-undergo nga treatment. Okay, the actual process is generally not painful. Nagpa-dictros ra sila, makikita ka sa mga patients na was chemo unit, naka-smile ra. Okay, IV placement may cause temporary discomfort, but the infusion itself is usually painless. And yeah, sometimes, so you see the cancer patient there in the picture, sometimes sila ng expert, nakapila na nga cycle, and then some new cancer patient gets enrolled, nga sila pa yung, okay ra ng chemo, ara na kurat. So sometimes it's, you have your own patient cancer support group already built in when patients nagtapok-tapok together in the waiting room. Sige, number 4, all chemotherapy makes you vomit. True? False? False. Okay, it's a myth. Okay, just like not all chemo makaupaw, not all chemo makasuka. Okay, so not all chemo drugs cause nausea and vomiting. It is a common misconception that everyone undergoing chemotherapy experiences severe nausea and vomiting. So these side effects are still possible, okay, with some drugs, but advancements in anti-nausea medication, so as in the picture, ondansetron is one of them, these have significantly improved the ability to manage and prevent these side effects. So even before pa itaod ang chemo infusion, mag-inject na ang nurse 30 minutes before og mga anti-nausea medications. Uy, kurat. Number 5, chemotherapy is the only cancer treatment. Myth or fact? Myth, okay? So I'm sure nakadungog na mo sa statement or kanang usuron nga slogan nga. Diba? If you have outdated ideas or kanang di ka updated sa issues, ingnan ka, 2026 na. Okay, 2026 na guys. We have many developments already in cancer treatment. So chemo is not the only option. Okay, so chemotherapy is just one of many available cancer treatments. And depending on the specific case, the patient's treatment plan may include surgery, radiation therapy, immunotherapy, hormone therapy, but sometimes all of the above. Just like a typical breast cancer patient, the chemo can be given before the surgery, or pwedeng nag-surgery na siya outright, but she will still need chemo after, and after chemo, radiation. Okay, so we need to clarify this journey to the patient even from the first visit. Okay, so cancer care involves a multidisciplinary team of healthcare workers. And For patients that are totally afraid of chemo, there are other options such as targeted therapy also and immunotherapy. Okay, so 2026 na, di ta confined anang mga chemo lang. So cancer surgery, chemo, radiation therapy, immunotherapy, targeted drug therapy, which includes oral medications or intravenous medications. Okay, now we jump to radiation therapy. So this is just a typical diagram of the radiation therapy setup. So that's the radiation machine, or more accurately called the linear accelerator. So it uses photons, ionizing radiation, basically X-ray. So what you use to take an X-ray of your chest, they just use a higher power of that to burn tumors inside your body. So using high energy radiation and then targeted only to the tumor location. So this is the actual machine. So you have a C-arm that can move around, okay, so that it will only hit your tumor. So, number 6, everyone with cancer needs radiation therapy. Myth or fact? Myth, okay? So, not all cancer patients need radiation therapy. Okay, it depends on the patient's individual cancer diagnosis. It can be used alone, okay? So, pwede radiation alone as definitive or a palliative treatment. Definitive, so meaning radiation ra gyud iyang kailangan to achieve the cure. Or palliative treatment because, let's say, the patient is too frail or too elderly to receive any systemic treatment, so radiation lang ang only option, that's also possible. Okay? It can be used before or after surgery. It can be used before or after chemo or concurrent with chemo. So, the next slide, radiation is always given with chemotherapy. Myth or fact? Oh, if you read the previous slide, you can already answer this confidently with myth. Okay? So, not all radiation therapy must be given with chemo. Again, it depends on the patient's individual cancer diagnosis. It can be used alone as definitive or palliative. It can be used before or after surgery. It can be used before or after chemo or concurrent with chemo. So, one drug we use with radiation therapy is cisplatin. And then you can see here, such as in head and neck cancers, given as chemoradiation, or in cervical cancer, concurrent with radiotherapy. So these two terms are synonymous. Chemoradiation means chemo being given concurrent with radiotherapy. Okay, number 8. Oh, hapit na ta sa 10. Your whole body receives radiation during treatment. True or false? False. Myth. Okay? So, as we showed earlier with the C-arm of the LINAC, no, radiation treatment is a form of localized therapy. Okay? Only aimed at parts of the body that need treatment. Okay? So, pwede i-focus lang yun sa tumor nga gi-target. So, the radiation oncologists have their own techniques to do this, and they even have to work hand-in-hand with our medical physicists. No, time's up na daw ko. Last 2 slides. The side effects of radiation are the same as chemo. Myth or fact? Myth. Okay, so as you can see here in the diagram, chemotherapy, infusion siya. Okay, sometimes chemo is also oral. Either of the 2 modes of administration, systemic, whole body ang effect. But radiation therapy, local. Kung unsa ray site nga gi-expose, mo ray affected. Okay, so myth. Side effects of radiation are localized to the area being treated. Skin irritation is common because you don't open up the patient. Okay, so it has to pass through the skin. Nausea or vomiting can happen if the radiation is aimed at the stomach or bowels or even the head, the brain. And hair loss may happen if radiation is aimed at the head. Okay, so area na maagian ng hair follicles, kana nga part ang maupaw. Dili total hair loss. And then, next, radiation is contagious. Myth or fact? Myth. Okay, kay mo sa ng hadlok patient do, kay mag-radiation ko, dili ko kauli sa balay, etc. So, to debunk that myth, receiving radiation does not make the patient radioactive. Mura ra gyud magpa-X-ray, nagpa-chest X-ray ka, uli ra ka, gawas ra ka sa room dayon, pwede ra ka ma-expose sa laing tao. So, same as radiation therapy. So, a patient receiving radiation therapy won't transmit radiation to others around them. Patients are safe to be around family members and pets after radiation oncology treatment. So sometimes you have to specifically tell the patient this. Kaya hadlok na sinon sila makigtupad sa ilang bana or makishare og pagkaon sa ilang parinti. kuan lang, exception is radioactive iodine treatment, which is different. You are intaking a radiopharmaceutical, so this is under nuclear medicine. So that is different from radiation therapy. Patients receiving RI may have to limit their contact with others for several days, and then pwede na mag-back to normal. Okay, so that ends my lecture. My references for this are cancer centers abroad that are known globally for cancer treatment. Dana-Farber, Fox Chase, and our vision at VSMMC is one day we will be at par with these globally recognized cancer centers. Thank you very much.
Okay, thank you, Dr. Amelia Marie de Vera, for the myths and facts of chemotherapy and radiation. For the updates of cervical cancer screening, let's welcome Dr. Karen Cris Barbosa, Medical Specialist 2 of VSMMC. Thank you so much.
Good morning, distinguished representatives of the local government units, health partners, and stakeholders. We appreciate your presence today as we address the critical pillar of women's reproductive health, cervical cancer prevention and elimination in Cebu. Cervical cancer remains a significant public health challenge in the Philippines and within our province. However, it is uniquely preventable and highly treatable when detected early. Today's presentation outlines our coordinated provincial strategy to strengthen screening systems, expand access to modern diagnostics, and ensure timely referral and treatment. This initiative is a collaborative effort between the local health offices, Vicente Soto Memorial Medical Center, the Department of Health Region 7, and JPIGO. Our objective is clear: to strengthen early detection systems and ensure that no woman in Cebu is left behind in accessing life-saving care. Cervical cancer continues to be one of the leading malignancies affecting Filipino women. In Cebu, referral hospitals such as Vicente Soto Memorial Medical Center continue to receive patients diagnosed at advanced stages. This highlights persistent gaps in early screening coverage and follow-up systems. The solution is not solely hospital-based care. It requires strengthening primary health centers, empowering barangay-level services, and ensuring structured referral systems across the province. With JPIGO's initiative, the Success Project, or the Scale-Up Cervical Cancer Elimination through Secondary Prevention Strategy, was implemented from 2021 to 2022 in partnership with DOH Region 7, Vicente Soto Memorial Medical Center, and Ming Lanilla Health Office. The project aimed to strengthen screening access across Region 7 with key implementation sites at Vicente Soto Memorial Medical Center and Ming Lanilla Health Office. Healthcare workers were trained in HPV DNA testing, visual inspection with acetic acid or VIA, and thermal ablation. Through this initiative, primary care facilities were capacitated to provide early detection and same-day treatment of eligible precancerous lesions. The Success Project laid the foundation for decentralized accessible cervical cancer prevention services across Cebu province. To further modernize our approach, JPIGO operationalized the CLAMS project, or the centralized laboratory model for HPV DNA screening that was implemented from 2024 to 2025 in Cebu City. Healthcare workers from different units of Cebu City were also trained in HPV DNA testing, VIA, and thermal ablation. The CLAMS operates using a hub-and-spoke model. Specimen collection at the city health centers and the samples were brought to centralized laboratory processing for standardized quality-assured testing. This system enhances diagnostic accuracy while maintaining accessibility at the community level. Eligible patients with positive HPV results may undergo thermal ablation at designated hubs in Cebu City, while suspicious or complex cases are referred immediately or directly to Vicente Soto Memorial Medical Center for advanced evaluation and oncology care. GPIGO is currently strengthening digital tracking systems and structured referral pathway to reduce loss to follow-up and improve continuity of care. And with that, a structured referral pathway ensures efficient and timely management. The patient begins with HPV DNA testing collection at the primary health facility. If the result is negative, she is advised to return for screening after 5 years. If the result is positive, she undergoes further evaluation. Eligible precancerous lesions are treated with thermal ablation at the hub facility. If suspicious, cervical mass or invasive cancer is identified at any point, immediate referral is made to Vicente Soto Memorial Medical Center for colposcopy, biopsy, or oncology management. This algorithm ensures that early treatment at the primary level, appropriate triage of complex cases, and reduce delay in tertiary care referral. In our public health centers, the standard screening modalities remain to be pap smear and VAA. Pap smear is a cytology-based test that identifies precancerous cellular changes. Negative results typically warrant repeat screening every 3 years, while VAA is a cost-effective real-time screening method. VAA supports a screen and treat model. So once the patient is VAA positive, we can immediately treat these patients, allowing same-day decision-making and intervention. Pap smear and VAA remain the backbone of public cervical cancer screening in Cebu, and CLAMS enhances these services with available HPV DNA screening, but does not replace pap smear and VAA also. So to compare available screening tests, this table shows the pros and cons, age range, and recommended actions for positive results. For pap smear, the advantages include being widely available and capable of detecting early cellular changes. However, it has moderate sensitivity, which means it can sometimes miss lesions, and it requires lab infrastructure and trained personnel. The recommended age range is 21 to 65 years following ACO guidelines. And if the result shows abnormal cells, the next step is either reflex HPV testing or colposcopy. Next is the visual inspection with acetic acid. So this is a low-cost, immediate method where acetic acid is applied to the cervix and abnormal areas turn white. Its biggest advantage is the ability to provide same-day results and treatment, which is very useful in low-resource settings. But VIA is operator-dependent and less specific, and it may miss some lesions. VIA is typically recommended for women aged 25 to 49 years old, and a positive VIA result can lead directly to same-day treatments such as thermal ablation or referral to a higher-level facility if needed. And finally, the HPV DNA testing detects high strains of human papillomavirus that can lead to cervical cancer. This method has the highest sensitivity, meaning it's very effective in identifying women at risk, and it allows for longer intervals between screenings. Its limitations are lower specificity, higher cost, and the need for molecular testing labs. The recommended age range is 30 to 49 years, or 30 to 65 years according to the local programs like the PHEX. If the test is positive for HPV 16 or 18, immediate thermal ablation is indicated. In summary, each method has its strengths and weaknesses. Pap smear are reliable and widely available. VIA is practical for screen and treat programs in low-resource areas, and HPV DNA testing provides the most sensitive detection. Programs often combine these methods depending on resource population and national guidelines. Currently, in Cebu City, we are actually having a combination of HPV DNA testing and VAA. So the table should serve as a quick reference for age eligibility, pros and cons, and follow-up recommendations for each screening modality. In summary, our initiatives have focused on strengthening secondary prevention of cervical cancer in Cebu. The Success and Clowns project enhanced local capacity for screening and treatment and expanded access to high-sensitivity HPV DNA screening through centralized laboratory processing, particularly benefiting urban areas. At the same time, pap smear and VA remain essential and foundational screening tools. Importantly, structured referral pathways ensures that women who screen positive are properly managed and followed up. Our work aligns with both national and global cervical cancer elimination strategies. The target population is women aging 30 to 49 years, ensuring they are regularly screened and appropriately managed. Screening alone is not enough. Appropriate follow-up and treatment complete the continuum of care. While advances in technologies such as HPV DNA testing are transformative, technology alone cannot eliminate cervical cancer. Community mobilization plays a crucial role. Women must be informed, encouraged, and supported to access screening services. We respectfully call upon our LGU leaders and partners. First, advocacy at the barangay level ensures awareness and participation. Second, adequate allocation of resources is necessary for sustained screening services. The third, strengthening referral coordination ensures no woman is lost to follow up. These system-level supports are essential to success. Early detection is not just a clinical metric, it saves lives. Every screened woman represents an opportunity to prevent cancer before it develops. Together, with strong leadership, community engagement, and sustained commitment, we can move Cebu toward a cervical cancer-free future. Thank you, everyone.
Thank you so much, Dr. Balbosa. Truly, early screening saves lives. So that line doesn't go old, for it will always be true to life. And thank you again, Dr. Balbosa. So at this juncture, we will now be talking about empowering local health unit and the current trends and future management of breast cancer. And to grace us with his presence today, please help me welcome medical specialist from Vicente Soto Memorial Medical Center, Dr. Plen Voltaire de la Peña. A big round of applause, please.
Hi guys, good morning. So I'll be lecturing about breast cancer. So how will we empower our local health unit with the current trends and future management of breast cancer? I am Dr. De La Peña, and these are my objectives of today's lecture. So what is breast cancer? So breast cancer is a malignant tumor that starts in the cells of the breast, okay? So as you can see on the picture on the left side, it will show the major components of breast tissues. So we have the lobules and the ducts. So these lobules are called glandular tissues that produces the milk for lactation. Then your ducts, that carries the milk to the nipple areola complex. So these are the common tissues in the breast. That's why we have invasive ductal carcinoma, not invasive lobular carcinoma. So breast cancer happens when cells begin to grow out of control, And the most devastating part of this is that it can metastasize to other parts of the body. So since the growth is out of control already, so we have a malignant tumor forming, which is a group of cancer cells that can invade the surrounding tissues of the breast, as well it can metastasize to the axilla, which is the lymph node basin for the breast, as well to different parts of the body. So the disease occurs almost entirely in women, but men can get it too. So in the Philippines, we have the most common cancer is the breast. And in 2022, around 33K was diagnosed. So based on the data of the Philippine Cancer Society, around 65% of breast cancer in the Philippines is already in the advanced or late stage. And the survival rate is only at 44%. So advanced meaning it's only in the stage 3, stage 3B, or the metastatic ones of breast cancer. So this is the incidence, and this is how often we encounter patients with breast cancer. And we are advocating early detection, early diagnosis of breast cancer, so that the earlier we can catch it, the higher the survival rate. In this lecture, I'm trying to illustrate what we are going to do if we have a clinical encounter in our local health unit. So our role as a primary healthcare physician in dealing patients in the community is to prepare these patients for advanced management in secondary and tertiary hospitals. So to elaborate, I would like to start with a case of PG, a 52-year-old female who came in with a mass palpated in the left breast around 3 by 2.5 cm. It was tender, movable, no skin dimpling, no nipple discharges, and no lymphadenopathy. So if we have a clinical encounter in the community, so we have to start with a thorough history and physical examination. But the question now is, what asa mo focus? So what makes a patient at risk of developing breast cancer? So these are the risk factors of patients, increased risk of breast cancer. So every woman is at risk of developing breast cancer. Her risk increases as she gets older. Around 75% of all breast cancers occur in women over 50 years old. And the following risk factors are exposure to hormonal exposure in estrogen, early menarche, late menopause, never giving birth or had her first child delivered beyond 30 years old, and family history of breast cancer. Other risk factors includes radiation exposure, obesity, alcohol consumption, and hormone therapy. So after looking at these different risk factors in terms of environmental exposures, as well as genetic predisposition of the patient, we now look at the physical aspect. What are the signs and symptoms of breast cancer? So these are the lumps, thickening, swelling, skin irritation in the breast, dimpling, distortion, or asymmetry, as well as new onset of nipple retraction, wound that does not heal, and bloody nipple discharges. So after this encounter, we have our complete history, the risk factors, and the physical examination. The next question would be, is the patient at risk or not? So after this one, we have different risk assessment tools that will tell us if the patient is really at risk of developing breast cancer. So the common one is the Gale model for breast cancer risk. We have new ones like BRCA Pro risk calculator and Tyrer-Cuzick risk factors assessment calculators. Now, among these risk factors, what does NCCN say, or the National Comprehensive Cancer Network recommend? So among this, there are 6 groups of that increased risk category for breast cancer. So those who have lifetime risk of 20%, defined by the models that was mentioned. Those that receive prior thoracic radiation therapy between ages 10 and 30. Those 35 years old with a 5-year risk of invasive breast cancer with a Gale model calculator risk of 1.7%. Those who have lifetime risk of greater than 20% based on the history of atypical ductal hyperplasia. And those with risk of 20% or more with carcinoma in situ and atypical lobular hyperplasia. And lastly, those with a known genetic predisposition or pedigree suggestive of a genetic predisposition. So, if our patient belongs to these 6 groups, so we can go now for further workup and imaging. Another question upon is what imaging we will request, especially at the local health unit, kung kita'y una nakakita. So, imaging test to be required. So, based on the NCCN, if we have a clinical encounter with a palpable symptom, the first imaging test that we need to request is a diagnostic mammogram with tomosynthesis or the 3D mammo plus the ultrasound. Same thing with patients with nipple inversion with no palpable masses and patients with nipple discharges and no palpable masses. Especially in patients aged greater than 30 years old, diagnostic mammogram with tomosynthesis plus ultrasound is recommended. Mammo and ultrasound has a complementary roles which increases the accuracy and detection rate of breast cancer or any breast masses or lesion. So our patient underwent mammogram and ultrasound which showed a mass on the left lower quadrant. So our counterpart in radiology and ultrasonography will give us a reading and it is classified based on BI-RADS. So these are breast imaging reporting and data system. So ilaning simplify for us so that we can interpret it. So with this category, it increases from BI-RADS 0 to BI-RADS 6. And along this, it gives us the likelihood of these patients with malignancy. It depends on the characteristic and features of the ultrasound images that you will look at. So for BI-RADS 2, these are benign findings. Essentially, the likelihood of malignancy is smaller or nearly 0. It increases to BI-RADS 4. The suspicion of malignancy increases. What is nice thing again with breast imaging or the BI-RADS system is that it also gives us recommendations on what to do kung unsa ni siya nga BI-RADS. So BI-RADS 4 and BI-RADS 5 will recommend for tissue biopsy and tissue diagnosis. Okay? So another question now after the imaging and interpreting the BI-RADS system. So what biopsy? We have the fine needle aspiration biopsy, core needle, incision, excision. So based on ESMO, ASCO, and National Comprehensive Cancer Network nga guidelines, the recommended biopsy is your core needle biopsy. Core needle biopsy provides us a histologic specimen with preserved tissue architecture, allowing for evaluation of the invasiveness, the receptor status of the patient, the tumor grading parameters for the critical treatment planning. Mo gyud ni siya ang very important. Since both FNAC and core needle biopsy are reliable diagnostic modality for evaluating palpable breast lesions, core needle biopsy provides superior accuracy and agreement with histopathology. We will discuss further later why important ang kaning we can send the specimen more for receptor status and other grading status. So after core needle biopsy, we will have our diagnosis. So may it be non-invasive type of breast carcinoma, your ductal carcinoma in situ and lobular carcinoma in situ, or invasive ductal carcinoma and all other types of breast cancer. So our patient underwent ultrasound-guided core needle biopsy, which showed invasive ductal carcinoma and Nottingham grade 2. So after this one, if we have the diagnosis, we will do immunohistochemistry of this patient. So immunohistochemical staining will tell us the ER/PR and HER2 status of the patient, whether it is positive or negative. So the table below will tell us the intensity or how intense ang estrogen receptor status of the patient. Sometimes we get a HER2 equivocal status. That's why we need to do a FISH test for this patient. These are very important, the immunohistochemical staining, because it will give us the subtypes of breast cancer. So your breast cancer has a different subtypes. It has its own personality. So it may be divided into 4 to 5 groups. So you have luminal A, and luminal B, the luminal type of breast cancer. We have the HER2 enriched and the triple negative. So ang difference, ani, is the management na to. Because these types, the luminal types of breast cancer, has, dili kayo siya sensitive with chemotherapy. And the luminal types are more sensitive with hormonal treatment. And the more aggressive type, the HER2 new, the HER2 enriched and the triple negative type of breast cancer, the most aggressive one, are very responsive with chemotherapy. So if we don't follow these guidelines, ma-miss na to ang chance the benefit of giving neoadjuvant treatment in patients, labi na ang patients with HER2 enriched and triple negative. And these are the aggressive one, or the aggressive types of breast cancer. In terms of the metastatic workup, the current NCCN recommendation promotes symptom-directed nga metastatic workup. So, bone scan or other tests will be requested if there are symptoms of the patient. Okay? So, this is the snapshots from the NCCN. So, what I'm trying to explain also that for our institution, we're accepting Z-benefit package. And these are the mandatory Z-benefit package mandatory requirements for our institution. So if ever manggod lacking or wala na to gibuhat ng what is given in the guidelines, it will entail patients nga ma-delay for their treatment from the first encounter until diagnosis. So our patient underwent invasive ductal, the final diagnosis was invasive ductal carcinoma, T2N1M0, and underwent MRM on the left. And my time is up. And with the uniqueness of every breast cancer patient, we can empower our local health unit through proper assessment, workup, and updated management. So this would be very helpful for our breast cancer patient para maiwasan na to ang mga delay and magbalik-balik from our clinic to the referral na hospital. And that would be all. Thank you.
Okay, thank you, Dr. Glenn Voltaire de la Peña, for the Empowering Local Health Unit, Current Trends and Future Management of Breast Cancer. And moving forward, for the Colon Cancer 101, let's welcome Dr. Sirio Angelito E. Orjalesa, Medical Officer 4 of VSMMC. A round of applause, please.
So before I begin, I would like to thank the organizing committee for inviting me as one of your guest speaker. March is a colorectal cancer awareness month, so I think this is very timely for us to give a short preview on what's going to come or what we are trying to share as our advocacy in our section. I think before I begin, when I say colorectal cancer, you answer me, we can prevent it. Again, colorectal cancer? Thank you. Inyon. So here it goes. So what is colorectal cancer? So for us as a colorectal surgeon, this is part of our the anatomy that which we are explaining to our patients. As a surgeon, we try to explain it at their level. I always correlate it with our specialty here at Cebu, which is the ginabot. No, this is the large colon, which is I say to them na sumpay sa ginabot. So we have the large colon down to the rectum. So how do I get colon or rectal cancer, and how common is it? As we all know, this is the adenoma carcinoma sequence. We have about 10 years to catch patients before they develop colorectal cancer. So this is the good venue for us to at least catch them early, to give them the early screening and to provide to them what are the necessary services that we can offer at our institution. For the leading causes of cancer, both sexes, we identified colon and rectal cancer as the third for both sexes. As for the male, it's second to lung cancer, and as for the female, it's second to breast cancer. This is from the Globocan. Now, as for the mortality, it's around 57%, which is third to the two leading cancers on both sexes. I think as a fellow in training for the colorectal cancer cases, mostly we catch patients at the advanced stages. Mostly they are stage 3, and sad to say, they are stage 4. So I think the importance of screening is very important in terms of a primary healthcare provider. So we have the incidence of death, it's more of 3,000 from the year 2017. I think the figures would increase. So what are the risk factors? We have the modifiable and the non-modifiable. We have the aging, or the age, the hereditary risk factors. We have the IBD. We also have the environmental, our diets, and our usual vices. We have the non-modifiable. I think we are all at risk here because of as we age, there are changes within our body which predisposes us to such malignancies. We also have our family history, the hereditary risk factors, and our first-degree relative, and also our personal and social history. These, I guess, are very important, wherein we do screening, we check them, the risk, and how we educate them in terms of screening and management. This is very important, no? Our diet. This is very, in terms of giving health teachings, I think we are all guilty here. These are the best foods that we can get, so easily accessible, and I think we would all agree na it's very delicious. So these are part of the risks that we encounter if we develop a colorectal cancer. And also alcoholic drinking. I think most of us, or some of us, would do drink alcohol. I think this is we are all aware of the risk that these vices gives us, together with cigarette smoking. Now obesity. I think I'm also one of the candidates of that risk factor. So I guess these are modifiable risk factors wherein we need to control as part of our prevention of developing colorectal cancer. And what should I watch out for? These are the symptoms that we need to educate our patients. Signs and symptoms of a colorectal cancer, but this is, I guess, this is non-specific for our cases. Other diseases would also present with such signs and symptoms. We have the diarrhea, constipation, change in the stool consistency, persistent abdominal discomfort or cramps, or sensation of incomplete voiding. Mostly patients would complain of bloatedness, They would complain of change in bowel habits, all of which were just tolerated at home. That's why when we receive patients, mostly they're on the advanced stages. They would again complain of fatigue or weakness, and some would present with unexplained weight loss. So these are significant weight loss for patients with colorectal cancer. So what should I do? Where should I go, and what will they do to me? So these are the usual questions that we need to address as part of the primary healthcare physician. Now, these screening tests are available at Vicente Soto Memorial Medical Center. The most basic requirement would be the FOBT. It was presented earlier by one of our speakers. We have the FIT or FOBT. FOBT is very available at Vicente Soto, which is around 377, so it's very cheap, and it makes a big difference in terms of screening for our patients. So how is colorectal cancer diagnosed? We have the option of first FOBT. If it turns out to be positive, we have the colonoscopy. Again, it's available. We have the blood test, stool test, or the flexible sigmoidoscopy, or the CT scan. Now, the current recommendation is to do screening at the age of 45. For patients who are high risk, they can start as early as 10 years from the age wherein their first degree relative is diagnosed with colorectal cancer, or if they reach the age of 40. So we can do screening for these patients. We have the FIT, so I'm very excited from hearing from the other speaker that there's already ongoing from the Bicol region regarding the FIT test. And also we have the multi-target stool DNA test and also the FOBT. The DNA test, I think the higher institution has this test available. We have the colonoscopy. Again, we have our friends from gastroenterology who does the screening for patients. We have the colonography and the flexible sigmoidoscopy. So what are the alternative treatment for patients with colorectal cancer? We have the surgery. Surgery, I think, as a primary care physician, I think it would be better if we focus more on the prevention. I think mostly, as what I have mentioned earlier, as much as possible, we would not like to do surgeries on our patients who have an advanced cancer cases like the rectum and the colon cases. The chemotherapy from the IM Onco and also the radiotherapy from our friends from radiology department. As a summary of our talk for today, an ounce of prevention is worth a pound of cure. So I guess that's our advocacy for the Colorectal Cancer Awareness Month. Thank you and good morning.
Thank you so much, Dr. Orjalesa. And now to grace us with one more topic before we have lunch. So, friends, let us all welcome another speaker from Vicente Soto Memorial Medical Center to talk about the fuel to fight, nutrition for cancer prevention. Ladies and gentlemen, please help me welcome Dr. Ruth Chanco. Big round of applause, please.
Good morning, everyone. So I'll promise I'll make my talk short because I know maybe all of us are hungry because I'm feeling hungry too. So even though the talk about nutrition usually takes up a lot of time, it really involves a lot of discussion, but as much as possible for now, I will try to make it shorter. So foil to fight, nutrition for cancer prevention. So as discussed earlier by the previous speaker, we all know that cancer is very expensive. So as much as possible, we advocate not to have cancer. So these are my objectives, but I will not go into that to make it shorter. So according to the World Health Organization, 1 in 5 people worldwide develop cancer during their lifetime. And prevention of cancer has become one of the most significant public health challenges of the 21st century. So it has a critical role in the fight against cancer. So based on the current scientific evidence, at least 40% of cancer cases can be prevented. So we can prevent it. So if cancer can't, so we can, right? So this is a press release from the World Health Organization dated February 4, and it states that 4 in 10 cancer cases could be prevented globally. So it can be prevented through, although they emphasize that in these studies, they examined 30 preventable causes, and it involves including tobacco, alcohol, high body mass index, physical inactivity, air pollution, and the 9 cancer-causing infections that can be prevented to cause cancer. So the findings highlights the enormous potential of prevention to reduce the global cancer burden. So I just include this in my slides to show you that this is from the World Health Organization, showing that cancer is attributable also to obesity. So it's still the root cause, although it's one of the causes of cancer. So this is also another study from the British Journal of Cancer, published last September 2024. So it still entails that metabolic obesity can still cause cancer. So this is now our advocacy to prevent occurrence of obesity or increase of high body mass index. So this is just the schematic diagram showing you that of all the cancers that is caused by obesity, breast mass takes up has the highest percentage, followed by the uterine carcinoma, the liver, the colon, and among others like the kidneys, pancreatic, and gallbladder carcinoma. So I am just showing you here the relationship between nutrition, obesity, and cancer. So nutrition is what our body needs on a daily basis to stay healthy. However, when nutrition becomes, here. So this is I'm just showing you the relationship between nutrition, obesity, and cancer. So when nutrition becomes a problem, so it can lead to obesity. So in turns, if obesity is left unchecked, so then it can result to cancer. So these are the health implications when our body mass index increases. So I've shown there, it can lead to cancer such as breast, uterus, cervix, colon, esophagus, pancreas, kidney, and among others. So why is it happening today? So why did food becomes our problem? So what are we eating these days, right? So here it is. So these are the culprits. So here is just an example. I have here hot dogs. So this is an example of the ultra processed foods, the Cokes, the sugary beverages, the sugary foods, the ultra-refined foods. So even though I'm standing here in front of you, but still I am guilty, right? I admit I'm still guilty. I'm still on my way to changing my diet, even to my family. So this is just research about the culprits foods that can cause cancer. So one of them is the ultra-processed foods. Examples are the hot dogs, mga canned goods, like that. So they can really cause cancer in the long run. So it amounts on how the longer you eat more of them. So it does not occur in a day or weeks. It occurs after a year of eating them. So how do we turn our life around? So what can we do? Knowing all those can cause our cancer. Although it's hard to do, but we have to. So we advocate lifestyle modification. So in lifestyle medicine, we advocate, we focuses on the 6 areas to improve our health. So namely, they are the healthful eating, physical activity, manage stress, avoidance of risky substances, we improve our sleep, and form and maintain relationship. But for today, we will focus only on healthful eating, how to go about it. Because if we have to discuss all these 6 areas, we will not be able to eat our lunch. So we'll just focus on one, on this nutrition. So how do we start to turn our life around? So in terms of health, when we discuss about healthful eating, so lifestyle medicine, we advocate for, our goal is to move our patient to having whole food plant-based diet. So maybe you wonder, what is whole food plant-based diet? It's not totally that we go vegan, but we just have to eat food close to its natural state. Like, for example, apple. You eat the apple, not the apple pie flavored apple. Okay, it's mixed already with refined sugar. So whole food, the real one that we get from the market. So this one. So this just as a study. So this study was conducted last August 2025. So this proves that having plant-based diet can decrease the risk of having cancer and developing cardiometabolic diseases. And this picture is very common. We can see this in our Facebook page. They usually pop up. But I can see that this is really true. You are what you eat, so you become what you eat. In my household, no, my kids are the living proof that they become what they eat. Because I have 2 kids. I have a daughter, 13 years old. So he really loves to eat vegetables, on fish, on fruits. And she is a very slim, very active kid. And I have also my younger son. He is 9 years old, but he has autism. So autism, as we all know, they are very picky eaters. So it's very difficult to feed him. So he usually likes to eat crunchy food, fatty food. So this is him on the right. So he is a 9 years old weighing 50 kilograms. So that really scares me. Okay, it's really hard to explain that how I can shape his diet. But although now that he is older, before, when he was 3 to 5 years old, it's really hard to change his diet because he's going to tantrums if we cannot fulfill his wishes. But now that he is 8 to 9, as he turned 8 and 9 this year, so it becomes a little bit easy because he can now listen to reason. So also, he is autism who belongs to a nonverbal. So when you say nonverbal, he seldom express himself. So every time when he expressed himself like, Mommy, I want to eat hot dog, I miss hot dog. So I would be very happy hearing him say that. So sometimes I cannot help but oblige. So I will buy him hot dog the next day. But now that he is 9 years old, so every time when he expresses something that he wants to eat, he listens to reasons now. So when he asks, like, Mommy, I want to eat hot dog, I can talk to him like, oh, we already have hot dog this week. Maybe in 2 weeks' time, we can eat hot dog again. So I'm really proud to say that now from eating hot dog 5 days a week during his early years, now we are going to once a week or one in every 2 weeks. I can oblige to him. So it's really difficult when it comes to nutrition, right? We have individual challenges, especially at home or even in the community, in our patients. When we discuss about nutrition, our patient really has a lot of questions, they goes into defensive mechanism. So they have a lot of reason not to go about your advices. So how to promote healthy eating? So we don't expect change to change overnight. So in our practice, usually we just advise patient to take one step at a time. We'll take it slow. So we don't really advise, it's not really helpful to advise patient, oh, stop na ka magkaon o karni, kay makadaot na siya, tanan-tanan. So we'll just, for me, in our practice, we just take it one step at a time. So one is we advise our patient to start with home-cooked meal. So we advise them to take less takeout, dining outs less, because there's a lot of advantage when we cook our meals at home. So aside from you are being together with your family, so you also know what is in your food, unsay inaasay mo ang pagkaon, unsa siya pagluto, unsay mga ingredient nga gigamit, compared when we order takeouts. So next step is start with adding vegetables. Because I know someone nga di gid siya ganahan mo kaon og vegetables. So karni ra gyud siya, no? So my advice for this kind of individuals, for this kind of patients is just advise them to start adding one vegetables. Like, for example, this one. The picture shows bacon mixed with enoki mushroom. So just one vegetable add in one meal. So if they like eating canned goods like corned beef, so we cannot expect them that if we advise them, stop eating canned goods, especially pag mga hypertensive patient na, it has a lot of sodium, so it can cause you to increase your blood pressure to rise. So instead of doing that, you can advise them, you just add one vegetables if you eat canned goods like corned beef, so advise them to add one kind of vegetables. So aside from potatoes, you can advise them to mix corned beef with cabbage or mix it with squash, just like that. As long as we are on our goal of moving them towards whole food plant-based diet. So we can also do the replacement method, like comparing one food with another, comparing the benefits that we get from one food to another. Okay. So in advising also this one, because we also have to individualize our patients, that we have different financial capacity. So just for example, in terms of oil, so we all know that olive oil is a very kind of healthy oils. However, the drawback is olive oil is very expensive. So if ever our patient cannot afford to buy olive oil, so we cannot force them to buy it. So instead, we can advise them that on the level that they can afford. So like we will help them compare like sunflower oil, compared to canola oils. Although I don't know, I forget the price, which one is expensive, canola or sunflower, but this is just for example. So comparing the two oils, if the patient cannot afford olive oil, so maybe sunflower is better than canola oil. So maybe the price difference can be pwede na siya ma-overlook. So maybe we can advise our patient to buy sunflower oil instead of forcing them na dapat gyud olive oil imong gamiton kay mo gina siya ang pinaka-healthy, right? So we have to give them choices. So another example is giving them choices of cheese instead of eggs and giving them eggs instead of hot dog. No. So I got the idea of the comparative strategy from this research. I've come across with this one from Medscape. It states that the new fat math is what to tell your patient about dairy. So in this study, they said that the new directive is to consume full fat dairy. So this is it's a news to us, right? Because it's been a while that no, fat is bad. But in this study, they said that the previous studies, there were discrepancies when the studies were done. That's why full fat dairy turns out to be bad. So since the theory of this one, when we introduce this to our patient, is like it's a kanang bago gid siya ma-turn over ang previous nga idea about fats. So researchers said na we can do the comparative strategies. So para to avoid confusion among our patients. So let's just do this. Compare the benefits among the food nga paliton sa ato ang pasyente. Right? Because the bottom line of the study is that whole fat dairy is the choice instead of something less healthy. So that's why you can also do the comparative strategy among your food. And this is another strategy also in advising your patient about their nutrition. So you have to plan ahead. Make a meal plan. Make a list. So this is very helpful, especially now in our current situation. Especially there's war ongoing in the Middle East. So we have to be very financially ready. Okay, now we can even experience now that the price of gasoline is increasing. So every time we go to the market, so we have to stick to our budget because we don't know when the war will end, right? So gasoline prices is now increasing, so basic commodities will also follow. The prices will also increase. So when we go to the supermarket, we also have to tell our patient that it's better to make plan or make a list on what to buy. So that we can avoid unnecessary needs that we will avoid buying unnecessary things for us. So better, although making plan is very tedious, no, but it will make time. This is for the benefits of our health and for our nutrition. This one, for us doctors, no, has any one of you do this, writing down nutrition prescription to your patient? Because in my clinic, I do this because usually when we talk to our patient, it usually takes a lot of time. Abot pa nag-isa ka oras, mag-istorya mo about nutrition. Yeah. Imong effort is ma-loss lang imong effort. Kaya every time magawas imong patient sa clinic, nalimtan na niya tanan imong advices about food. So, para dili ma-waste ang atong effort mag-talk sa ato ang patient inside our clinic, I usually write it all down. Example is like this. Just simple reminders them how to cook their food, your advices if you introduce vegetables in their daily life. So you try mushroom to season your dishes, just like that. Just simple advices that they can read on when they get home. So another example is like this, when we have to be specific, when your patient really asks, how many beans do I eat, doc? How big is the meat that I have to eat? So you can do this. You can write like cups, 1 cup of greens, how many servings of food. So you can tell them to give 2 servings of fruit in a day, like that. And all. So this one, writing it down for our patients. So there's a lot more, but in the interest of time, so I will just give you a reminders of this one. This is a documentary film in Netflix titled "Live to 100: Secrets of the Blue Zones." So this is a very good documentary, and you can learn about the 6 advocacies of the lifestyle medicine. So it involves the healthy eating, physical activities, and the likes. So this is about the blue zones. So these are the places that people here, they are the living proof that lifestyle modification can work. So this includes the Loma Linda in United States, Nicoya in Costa Rica, Sardinia in Italy, Ikaria in Greece, and Okinawa in Japan. So this is the end of my talk. So these are my takeaways. So let's maintain healthy weight, eat a diet rich in whole grain, vegetables, and fruits. So if cannot be helped, so just limit consumption of fast foods, limit consumption of sugar sweetened beverages, limit consumption of processed food, but as much as possible, let's stop doing this. Let's stop eating fast foods and avoid sugar sweetened beverages and all. So just a little reminders before we eat our lunch today. So our food should be our medicine, and our medicine should be our food. This is from Hippocrates. Because the beauty of food as medicine is that the choice to heal and promote health can begin as soon as the next meal. So here, let's eat a rainbow as we go forward to eating whole plant-based diet. Thank you for your attention.
Thank you so much, Dr. Chanko. So indeed, let our food be our medicine and medicine not be our food. So very timely for lunch. And so we have to stop, right?
Yeah, and our 2 remaining topics, which are the red flags for childhood malignancy and end of life, compassion in the final chapter, will be continued in the afternoon session.
Yes, and we were told that we will start exactly at 1 p.m. But for now, we will be having our lunch. So there's a 2-way buffet here in this area, and there is one outside. So I guess let us first bless the food before meals. May I request everyone to please stand up for our prayer. Let us put ourselves in the holy presence of the Lord, and of the Father, the Son, and of the Holy Spirit. Amen. Bless us, O Lord, and this thy gifts which we are about to receive from thy bounty through Christ our Lord. Amen. And of the Father, the Son, and the Holy Spirit. Amen. So please do enjoy our lunch.
And for today, for everybody's information, naatay photo booth available in the outside of the ballroom area.
So everyone, please enjoy your lunch. And please be back before 1 p.m. because we will be starting immediately by 1.
Okay, good afternoon. May I call the attention of the owner of vehicle GAU 6317? Again, GAU 6317 to please come here. Okay, naka-black daw ang inyong vehicle, ma'am and sir. Again, the owner of the vehicle, JAU 6317. Okay, good afternoon. We would like to announce that our photo booth is now available. It will be available until 2 p.m. Okay, again, our photo booth is now available po. Thank you so much.
Good afternoon, everyone. We will be starting in 10 minutes. The photo booth is still available outside. It will be closed by 2 p.m. Again, let me reiterate that we will be starting in 9 minutes. Thank you very much. Good afternoon once again. So we are starting in a few. Before we continue with this afternoon's series of lectures, let us also acknowledge the people, the participants who were sent by their respective organizations. So we have here this afternoon as well the VSMMC speakers. Thank you for gracing us with your presence. We also have our friends from the Cebu City Health Department. Can you wave? Give a wave. Okay, good afternoon. We also have Mandaue City Health Department. Hello. We have our friends from Governor Celestino Gallares Memorial Medical Center. But I know they're here. Yes, they're here. Also from the PhilHealth Regional Office. Okay, so thank you so much for coming here this afternoon. We shall continue with our program so that we will end on time as well. So to continue with our series of lecture, we will have the red flags of childhood malignancy to be given by our very own medical specialist too from Vicente Soto Memorial Medical Center, Dr. Hazel Valerie T.U. A big round of applause, please.
So good afternoon, everyone. So I'll be discussing the red flags of childhood malignancy and early detection for improved outcomes. So in the Philippines, we have an estimate of around 4,700 to 5,000 new childhood cancers annually, with an incidence of around 121 new cases per million. So the most common is your acute leukemia, followed by your brain tumors and your lymphomas. However, many children present at advanced stages, mainly because they are not recognized early. So our goals for the next few minutes are simple: to recognize the red flags, apply an urgency-based triage system, and know when to refer, because early recognition leads to early referral, and early referral can save lives. So the journey of a child with cancer often includes multiple barriers, and many of these problems begin with delayed recognition of your symptoms. And this is why awareness among us is extremely important. So the problem of delayed diagnosis of children in childhood cancer is an issue faced by many families in low-middle income countries. So the Pan-American Health Organization, or PAHO, together with WHO and St. Jude Research Hospital, created this guide as part of a global initiative to provide healthcare professionals with a practical tool for early recognition of signs and symptoms associated with childhood cancer. So its purpose is to facilitate the timely intervention, to start treatment in the early stages of disease, where the chances of therapeutic success are significantly greater. So in this guide, the signs and symptoms of each of 11 cancers are listed, and they are classified as requiring immediate priority or scheduled action based on the likelihood of cancer diagnosis and medical emergency the child faces. So we have here the stoplight classification. So it depends on the findings of your patient. So red means that we have to act now. So these are potentially life-threatening presentations that need immediate referral to the emergency room. For yellow, this means urgent but stable, needing priority care, wherein you can refer within 48 to 72 hours to a pediatric oncology service or unit. And for green, it does not mean that we will ignore the symptoms or the signs, but we need to do initial workup, reassess, and escalate if symptoms are persistent. So this triage system allows us to prioritize patients based on the urgency of their conditions. So for red, cases are pediatric emergencies and must be referred immediately, such as the following. So severe progressive headache, new onset seizures, motor weakness, respiratory distress due to a mediastinal mass, or signs of intracranial pressure. So These patients need to be referred to the pediatric emergency department and later on stabilized to a pediatric oncology center. So the yellow category requires referral within 48 to 72 hours. This means that it is urgent but stable and needing priority care. So if one or more of the following signs of symptoms are present, such as your testicular enlargement, painless lymph nodes greater than 2.5 centimeters, or with persistent headache, sudden crossed-eyed, scrotal pain, bulging fontanelles, persistent vomiting, regression of development, leukochorea, or unexplained organ enlargement, then these children may appear stable, but the symptoms may indicate an underlying malignancy that requires urgent evaluation. So for the green category or scheduled care, if one or more of the following are present, such as your unexplained fever lasting for more than 10 days, persistent fatigue, bone pains, generalized lymphadenopathy, recurrent infections, unexplained weight loss. So for these cases, initial tests may be performed, such as your CBC, X-ray, and your ultrasound. And if the symptoms persist or the results are abnormal, then these patients should then be referred to a pediatric oncology unit. So in the next few minutes, I will be discussing the most common childhood cancers and its red flags. So here is a 5-year-old boy presenting with fever for 3 weeks, treated twice as upper respiratory infection. However, he developed pallor, leg pain, and bruising. So his CBC showed a hemoglobin of 7, platelet 45,000, with note of blast on the smear. So let us reflect on this case. So initially, the symptoms seemed mild, so green. But persistence of the fever and new symptoms have prompted earlier investigation. And thus, the CBC was done, confirming the urgency or red emergency referral because of the presence of the blast. So the green flags for leukemia include persistent fever, recurrent infections, pallor, bone pain, bruising or bleeding, and lymphadenopathy. Recognizing these symptoms early allows us to perform simple diagnostic tests such as your CBC that can lead us to an early diagnosis. So another case of an 8-year-old boy presenting with headache for 2 months with morning vomiting and declining school performance. So later, he developed double vision and unsteady gait. So the primary physician will order an MRI showing a posterior fossa mass. So this actually illustrates how persistent headaches in children should not be ignored, especially when associated with neurologic symptoms, because the early referral prevented severe complications. So tumor of the central nervous system are the most common solid tumors in children, particularly between the ages of 5 to 10 years of age. So the signs and symptoms of your brain tumors depend on the location and the patient's age. So for example, in a less than 2-year-old, this may present as irritability, bulging fontanelles, or increased head circumference beyond the normal range for age, and regression of your psychomotor development. For children more than 2 years of age or in adolescents, they may present with mild to moderate headache persisting for more than 4 weeks and usually awakens them during sleep or appears while walking. So you may also notice deterioration of school performance, diplopia, exophthalmos, or ocular proptosis. So these symptoms in yellow require priority care, referral to a hospital with pediatric oncology services within 48 to 72 hours. The key red warning signs of brain tumors include your new onset seizure, unexplained lethargy or drowsiness, motor deficits and loss of strength, and signs of intracranial pressure such as your headache, nausea, and vomiting, wherein they need immediate referral to the emergency room. So next case, we have a 12-year-old female with 3 weeks history of cough, complaining of difficulty breathing when lying flat, and noted with facial edema. So lymphomas often present with painless enlarged lymph nodes, fever, night sweats, weight loss, and just in this case, a mediastinal mass causing respiratory distress. So for this case, this patient warrants immediate emergency room referral because of his or her symptoms. Any persistent lymph node enlargement greater than 2.5 centimeters, unexplained fever, weight loss, should raise suspicion and prompt further investigation. So another case, you have a 2-year-old boy with white reflex on flash photography with noted further evaluation. The patient was noted to have a white pupil, thus a referral to ophthalmology, revealing an intraocular mass. So this is actually a classic presentation of your retinoblastoma. So signs requiring urgent referral within 48 to 72 hours include the following. So leukochorea or your white pupil, sudden onset of cross-eyed, persistent eye redness, exophthalmos, and proptosis. So for the last case, we have a 3-year-old girl with painless abdominal swelling noted with the mother while the patient was bathing. No history of trauma. The patient had decreased appetite and occasional abdominal discomfort for the past 2 weeks. On physical examination, there is note of a non-tender abdominal mass on the left flank, and further workup showed a renal mass suspicious for Wilms tumor. So Wilms tumor usually present as abdominal mass, abdominal pain, hematuria, and hypertension. So in this case, the abdominal mass, we categorize it as yellow, requiring urgent referral within 48 to 72 hours. So in 80% of the cases, the clinical manifestation is actually an asymptomatic palpable mass, abdominal mass detected by caregivers or the healthcare team during routine examination. So we can do your complementary diagnostic testing such as your abdominal ultrasound, CT scan, CBC, and urinalysis, and an urgent referral to a hospital with pediatric hema-onco service within the 48 to 72 hours. So where are the hospitals with pediatric oncology services? So there are around 188 hospitals in the Philippines with pediatric hematologists or oncologists, and majority of these hospitals are private hospitals, but among the government hospitals that are designated as cancer centers, here in this photo is listed are the 11 public cancer centers with designated pediatric cancer navigators who can receive referrals from the community, and they will facilitate prompt consultation to the specialists. And I would also like to encourage you all to register to the PAHO or WHO virtual course on early diagnosis of cancer in children and adolescents. So this course is free, and there's the URL you can copy. So childhood cancer is treatable and often curable, especially when it is detected early. So by recognizing these warning signs and referring patients promptly, we can ensure that more children will receive timely treatment and survive cancer. So again, if it is persistent and the symptoms are progressive, then we have to investigate because early recognition and early referral will have better survival. Thank you very much for your kind attention.
Thank you so much, Dr. Yu. Again, no child should die at the dawn of life. So I know it echoed in each one of you. And to continue with that note, we will have the last lecture for this afternoon series of lecture. It is The End of Life, Compassion in the Final Chapter. This lecture will be given by another speaker from Vicente Soto Memorial Medical Center. He is a medical specialist in hospice and palliative care. Dr. Mark Vincent H. Lucero. A big round of applause, please.
Good afternoon, everyone. It's a good time to sleep because after eating your lunch, no? But again, as we sum up the rest of the lecture before, no, cancers are usually discovered late or advanced stage already. So again, wait. Sorry for the delay. I have 5 minutes na lang. So anyway, settings.
All right, so while we figure out technical things, we would also like to acknowledge the presence of our friends from Chongwa Hospital, Mandaue, Perpetual Succor Hospital, Cebu South Medical Center, Provincial Health Office of Cebu, and the Provincial Health Office of Bohol. Our partner, Rafi. We would also like to acknowledge our friends from CPH Balamban, CPH Bogo City, CPH Danao City, CPH Karkar City, from the Development Management Office of the DOH CVCHD, and of course, the various LGUs for coming here. We have from Alcantara, Badian. So are you all here? Balamban, Bugo. Thank you so much for coming over. Consolacion, representatives from Consolacion. We also have from Lapu-Lapu City, Bulhoon, and then the LGU from Danao City, again, Karkar, Consolacion, Cordova, Dalaget. So I hope you are all learning a lot from this morning and this afternoon series of lectures. By the way, there is still available coffee outside if you need one. Our coffee is instant ha, it's not brewed for those who are really liking the likes of brewed. But still, it has a kick. So go for the coffee outside. Okay, so again, we are live in Facebook and in the website of the Department of Health CVCHD. So you can share those videos online, hit the like and heart buttons, and spread our program for today. So again, we are live on Facebook and the official DOH website. So please do share and hit like and the heart buttons. So just a quick overview as well for the program today. After the lecture, we will be having our open forum. So prepare those questions, for they will truly be answered after. So we will have it after Dr. Lucero's lecture. And then we will be graced by Dr. Nikki this afternoon as well, and have updated cancer program design from the Ramon Aboitiz Foundation Incorporated. Another would be the presentation of the best practices in Mandaue City. This is a community-based cancer navigation. And from Cebu City, the CLAMS program. Interesting. So we will be learning a lot as well this afternoon. And of course, we will also be having the sharing of the cancer journey and the cancer program highlights and awarding of the top performing LGUs.
Okay.
Go
Sorry
ahead,
for
Doc
that.
Mark.
Time's up na daw. So anyway, can you flash this? So anyway, as I've said before, most of the cancers are discovered advanced already. So again, I'm here to identify and address that big elephant in the room, no? So My goal here is not to lecture about end-of-life care, but my goal here is to desensitize or destigmatize you, from discussing end-of-life care to your patients. Especially, palliative care is primary care. You don't have to refer the patient to a tertiary hospital just for palliative care. But anyway, I would like to start with, so we were all trained to be lifesavers. We've spent our careers fighting death, like it's the ultimate enemy. But here's the hard truth. Death has a 100% success rate. When we treat death as a medical failure, we end up avoiding the dying because we feel like we've failed them. But what if our greatest clinical win isn't a discharge improved disposition, but a peaceful night's sleep for a man who is in pain? What if the most heroic thing you do today isn't a code, but a conversation? So today, let's talk about shifting the goalpost. Let's talk about how we honor the life that is right in front of us. End-of-life care. So when cure is no longer possible, something far greater is required of us as healthcare workers, and it is compassion. End-of-life is not where medicine fails. It is where humanity is tested. And in that final chapter, how we show up is the treatment. So this will be our learning outcome. So in our book, it's 5 to 6 chapters regarding end of life, but I'm going to digest it in a few slides. But the point is, again, is to destigmatize this topic. So end of life care, what is really end of life care? So usually it is a care given to people who are near the end of life and have stopped treatment to cure or to control their disease, according to the National Cancer Institute. Other definition is, it commences when person has a diagnosis of terminal illness with less than 6 months to live. And curative treatments are no longer options. But the point is, how can you say that the patient has less than 6 months to live? Diba? So end-of-life care is given when a person is likely in the last months of life. It usually focuses on more comfort, the dignity, and the quality of life rather than cure. Now, let's go back to palliative care. Are end-of-life and palliative care the same? No. So palliative care is too broad. It's very broad. Okay, this is the definition by WHO. It's mainly prevention of suffering and alleviation of any symptom. But note that we're only not focused to the patient. We are also focused to the families. Palliative care helps manage symptoms and stress at any stage of illness. So I would like to discuss about what we call the palliative care model here in the Philippines. So before, the traditional approach to palliative care initiates appropriate and comprehensive palliative care late in the course of the patient's illness, while modern palliative care approach is provided to the patient and the family at the time of the diagnosis of a life-threatening illness or even earlier when it is strongly suspected or considered. So modern palliative care approach addresses the patient and family's physical, psychosocial, and spiritual issues and problems that occur during the entire course of the illness. And after the patient's death, there's more. We are also doing bereavement care. In fact, we do anticipatory bereavement care, meaning before the patient dies, we'll do that. We do anticipatory bereavement care to the patient and to the family. So curative treatment plan and palliative care runs alongside the entire journey. However, the role of palliative care increases while the disease progresses. So at the end of the road, when treatment stops, that final stretch is what we call hospice care. So what's the difference between hospice and palliative care again? So there's so many definitions, but just to, again, summarize it out. So palliative care starts at any stage of serious illness, even at diagnosis. Hospice care begins when treatment stops and comfort becomes the only goal. So, can patients still receive curative treatment for palliative care? Yes, you can still do. No? While in hospice care, the focus shifts entirely to the comfort of the patient rather than cure. Now, for example, when the patient and the family ask for hospice care, and of course we will explain to the patient and the family what is hospice care. So in hospice care, we're not focusing more on life prolongation, but we focus more on comfort. So when we say, for example, advanced stage cancer patients in and out in the hospital for the last 6 months, patient will offer hospice care. So what is really hospice care? So if, for example, the patient will have infection, pneumonia. So in hospice care, we allow the natural course of the illness to go its due course. No? Meaning, we will not treat the infection, we will not give antibiotics, but we will treat the symptoms. We treat the fever, we treat the increasing secretions, we treat the pain, we treat the delirium, and of course, the end goal is really a peaceful death. No? So, location. So again, as of this time, it varies. No, in US, Mungo, they have this hospice package. No, wherein if you will avail for hospice package, the Medicare will provide everything, subsidized. No, hospital bed, auto tank, all medications, including home visitations by a nurse or by a doctor. But there is mga motjud, no? You will be the one to buy those equipments and you will be the one to look for a caregiver or a doctor who will visit. Okay? The focus of treatment in palliative care usually focuses more on the comfort or symptom control, communication, and emotional and spiritual support. No? It helps patients live better for as long as possible. So in hospice care, comfort-only care plus family support and bereavement services. No? It helps patient die comfortably and with dignity. So all hospice is palliative, but palliative care is much broader than hospice. So dili siya ingon, when you go for palliative care, wala. You're going to. Later on, we will redefine the end-of-life narrative, no? Debunking common misperception in palliative and hospice care. So first is talking about death removes hope. Why people believe it? Mostly because healthcare culture often equates hope strictly with a cure. And if there's no cure, there's no hope. No? I would like to emphasize the hope shifts from cure to comfort, from quantity of life to quality of life, and from more time to meaningful time. Talking about death removes hope. So, talking about death does not remove hope, no? And yes, of course, they will cry. But again, disclosing just the condition and the prognosis will not really, is not really our goal only. No? We will try to give them options also. And that is where we go with palliative care. So evidence shows honest conversation reduce anxiety and increase trust. Now, we always equate crying from depression. Of course, you will expect that the patient will cry if you tell them that there's no more option for cure and you will die. And the disease will progress, symptoms might arise and might progress also. So of course, they will cry. But we will give them options. We give them information that we can still do. No? We can still offer you symptom control, no? A peaceful death. Palliative care means giving up. So why people believe it? Well, first of all, palliative care is active treatment of suffering. No? It's not a withdrawal of care. So palliative care is often introduced too late. That's why, of course, dying patient. Before, earlier, I think before COVID, usually the referrals are usually late. No? Dying na yun, actively dying ang patient. But now, it's getting better, you know. And the timing is also timely rapod kayo. So, again, we are not stopping care, we are focusing care. So it can be given alongside curative of life-prolonging treatment. Now, morphine administration means patient is about to die. So remember the movie Saving Private Ryan? No? This is where Doc Wade was mortally wounded, and they gave a handful of morphine shots until the end. So why people believe when you give morphine, patient is dying? Word of mouth, neighbors, movies, but again, I think the point here is that the disease has progressed. That's why the symptoms also progress and it becomes severe, and that's why we're giving morphine. And that's the correct analogy for that. So many families and even healthcare workers believe morphine means death is near. No? But morphine is not the last rites medication. It is a symptom control medication. We give it for pain. We give it for breathlessness. We use correctly. It does not cause death. It eases suffering. So always remember that in dying, in end of life, untreated pain causes more physiological stress than opioids. So, again, morphine does not hasten death, and properly dosed morphine relieves pain and breathlessness without shortening life. Now, have you watched this movie? If we stop disease-modifying aggressive treatments, we are causing death. This movie, just to burst your pop, for the plot lang, no, the patient has advanced stage cancer. The mother, Maricel Soriano, I've watched this last night because my mentor told me na I have to watch this one because it's about cancer. So this is advanced stage cancer, have brain mets already, multiple brain metastases. So what did the family do? So did everything possible, baligya, they have to sell the business, they have to go to, bisag na-scam na sila, just to persuade their mother to undergo treatment or chemotherapy. Again, there's nothing wrong about chemotherapy, okay? As long as it is in congruence with patient's preference and goals of care, okay? So, now, how to correct this one? So we do not cause death by stopping treatment. So stopping treatment does not cause death. Disease causes death. Our role is to choose how the patient reaches it. No? Stopping futile treatment is not euthanasia. It is ethically allowing natural disease progression. No? Now, everything must be done until the very end. That is our cultural belief, no? Pinoy biya. Until na hinutdanay, baligya tanan. Okay? So, doing everything does not mean doing every procedure. It means doing everything that benefits the patient. So the frequent source of misunderstanding in these goals of care is the interpretation of the phrase everything. No? In medical jargon, it is frequently used to connote the maximal medical attempts to save or prolong life, whether or not it is expected to be of benefit. So medicine is not about exhausting options. It is about choosing the right ones. So the concept of burden versus benefit. So every intervention must pass one question. Does this improve comfort, function, or meaningful survival? If the answer is no, it is not doing everything. It is doing more than necessary. Now, I'm near na. Okay. Specific kills. So first is prognostication. So end-of-life care is predicated on the recognition that there is an increasing likelihood that the patient is close to death. So one of the most common problems in the care of the dying is failure to appreciate that the patient is indeed close to death. So recognizing that a patient is imminently dying is a prerequisite for providing appropriate end-of-life. Or else, you will send that patient back to the hospital and then battery of tests again. Then again, the usual, doing everything. Now, terminal phase recognition, worsening of symptoms is indicative of entering terminal phase. So it is the time during which the patient undergoes an irreversible decline in function and well-being prior to dying. So it can last from a few hours to days and very occasional to weeks. So what are the symptoms? No? Symptoms, drowsy for extended periods. So what will you do? Usually, if the patient is dying, visitors, no, come and go, daghan kayo. Nausay, drowsy man, wala man kay gana, muli na lang ko. So again, it's the patient condition that is deteriorating. No? Profound and persistent weight loss. Pakan adaghan kay, wala, unsaon mo makapag-fight sa cancer kung dili ka mukaon. Profound and worsening weakness and fatigue. No? Social withdrawal. Alain ka na. Bati ang ganag siya batasan. Good, manang din na siya mapakita. No. It's because of the deterioration of the condition. Dysphagia and difficulty in swallowing medication. So one of our anticipatory guidance is to address this one. So refractory delirium, the physical signs, no, and so on and so forth. So I will just move on to the next slide. So communication. So much of our intervention, no, 80 to 90% is about communication. 10% is only the giving of the medication. So preparing the family. So care of the family is integral to caring of the dying patient. So if the patient is, again, withdrawn, socially withdrawn na, weak na, so you go to the next of kin. So that's what you are going to have communication with. So truth telling. So again, you can first step in solving a problem is acknowledging that there's a problem. So as doctors, we are legally bound to disclose every detail regarding the disease condition. So it includes the nature of proposed treatment, alternative treatment, and prognosis with possible risks and benefits of the procedure to the patient. So full medical disclosure promotes patients' autonomy by providing them the ability to make decisions from their own medical care. Now, advanced care planning. So advanced care planning, it's a process, no, of planning for future medical care in the event that the patient condition deteriorates. So those are the resuscitative measures. What are the preferences? So we'll ask the patient for that. Now, symptom management in final days of life. So 4 most common symptoms during terminal phase. I will ask you, what do you think is the most common symptoms in an end of life or in terminal phase? Pain? Breathlessness? It's delirium. So delirium has been found to be present in up to 88% of patients. In fact, refractory delirium is a poor prognostic factor and often heralds the terminal phase, no? Identified as the main indication for the use of palliative sedation. Next is dyspnea. So the second is not pain. Next is difficulty breathing. So up to 70% of patients experience dyspnea in the last 6 weeks of life. No? So it's expected na desaturation siya. So we'll prepare the oxygen. No? The third one is thermal secretion. So during that time, we will, as much as possible, we want to go for we will focus more on the dry side. No, ganahan mo ang pasyente is medyo dehydrated to allow this one to prevent the death rattle. Then the last one would be pain. Okay, so pain management continues to be crucial. So, and that would be the challenge of us. No, okay, the opioids are not readily available, especially to far-flung areas. Especially here in Cebu, Metro Cebu. Now, again, only essential medications should be given and they should be administered by the least invasive route that can provide adequate relief. So, if ever, dili siya sa kanang, di ba, later on, you will have dysphagia. So, ang next is, we go for a subcutaneous route instead of the intra-IV. No? Kaya magdisod naman, hupong kayo. Then an appropriate rule is to identify and seize any drug which does not contribute to the patient's immediate comfort. So we stop antibiotics when they are no longer work. We stop chemotherapy when toxicity outweighs benefit. So observation and investigations do not contribute to comfort should be ceased. So every 4 hours, every hour ng BP monitoring, no, we will decrease that one. No? And the loss of ability to swallowing, so that's what I'm talking about before. No? Now we have to anticipate. Now, last 2 slides. So this one. So this slide may look confronting, no? But its purpose is not to frighten us. No? It is meant to prepare us so we can respond with skill, calm, and compassion. So what this slide shows is that dying is not one single experience. Some patients take what we call the usual road. They slowly become more sleepy, then less responsive, eventually slipping into coma. So sometimes they will tell us this is the best way of dying. But it can still be frightening if no one explains what is happening. The others take the difficult road. No? Instead of becoming quiet, They may become restless, confused, tremulous, or delirious. They may hallucinate, mumble, jerk, or even have seizures that is not suffering from lack of will, faith, or strength. No? So it is really the brain and the body failing from the metabolic changes. So, and this is the most important message of this slide. No? These symptoms are not the patient dying badly. They are signs no, that the patient needs better symptom control. Now, end-of-life care is not about choosing how a patient dies. No? It is about ensuring whichever road they take, they do not walk it alone or in pain or in panic. So our role as healthcare workers is not to change the destination. It is to soften the journey. Okay? And this is my last slide na. So I would like to point out the book Being Mortal. So Dr. Atul Gawande, a surgeon, reminds us of a truth we can avoid in medicine. No? Our job is not simply to fight death, but to protect what makes life meaningful until the very end. We cannot stop mortality, but we can decide how our patients live in its presence. End-of-life care is not about surrender. It is about courage, the courage to ask that what matters most, to listen without flinching, and to choose comfort, dignity, and connection over unnecessary suffering. So my dear colleagues and healthcare workers, let us not measure our success only by how long we prolong life, but by how we faithfully honor it. Because in the final chapter, what patients remember and what families carry with them is not the machines, not the medications, but the compassion. And that is always within our power to give. Thank you.
Okay, thank you so much, Dr. Mark Vincent H. Lucero, for the end-of-life compassion in the final chapter. And at this juncture, may I call our speakers, including our speakers from the morning session, Dr. Hamela Marie de Vera, Dr. Karen Chris Bilbosa, Dr. Plan Voltaire de la Peña, Dr. Sergio Angelito E. Orjalesa, Dr. Ruth Chanco, Dr. Hazel Valerati Chu, and Dr. Mark Vincent H. Lucero for the giving of the Certificate of Appreciation. For the giving of Certificate of Appreciation, may I request on stage Mr. Doc Philip Baton, together with Sir Vincent Somergedo, Dr. Joan Albeto, and Ms. Servil May Villespin. Let me read the citation. Certificate of Appreciation is awarded to speakers in recognition of their effort, expertise, commitment as resource speaker during the second Regional Cancer Summit on March 5 to 6, 2026 at the Sarrosa International Hotel and Residential Suite, F. Cabahog Street, Casambagan, Cebu City. Giving this March 6, 2026 during the second Regional Cancer Dr. Ruth Chanco, Dr. Ruth Chanco, Dr. Hazel Valerie Chu, and lastly, Dr. Mark Vincent H. Lucero. Okay, may I request all the speakers now to be stay in stage as we begin our open forum. Okay, for the chairs. Okay, may I also request our PhilHealth representative, Dr. Elville Chu, to be on stage. And for the information of everybody, you may give your questions through scanning sa atong QR code. For those who have questions to our speakers, no? Again, you may put your questions, no? To our scanning our QR code nga nasa inyong mga table. And we also raise your hands if you have questions, Pod. Speakers, take your seat, po. May I also request the presence of Miss Avril Chu, Dr. Avril Chu.
All right, so we have our distinguished speakers here in front.
Are you guys ready for your questions, no?
I hope you are. One question per table, maybe?
They can also use the QR code for the questions.
So there are QR codes in your tables. If you're shy to raise your hand or stand up in front, you can type in your questions via the QR code. And we will be gladly reading them for you here in front.
Are there any questions now? I think Doc Van has question, no?
Yes, Doc Van.
Okay.
Oh, I've heard Dr. Orlando has a question. Okay, first to throw the question. Okay, so we have our first question here.
Doc Van from Mandaue.
Okay, Doc, take the floor.
Good afternoon. I'm Dr. Debbie, Mandaue City Health Office. My question is actually addressed to Mr. Vincent Sumergido. Kasi Mandaue City already has a cancer navigation clinic. And we see patients after doing the screening and preparing them for workups, diagnostic workup or confirmation. Unfortunately, I think the CAF is still limited to hospitals. I don't know, during last year, I attended the Philippine Cancer Network meeting, and we've already raised this question, sana you can share the CAF also to local government units who are already doing actively the screening, the diagnostic, before referring them to the higher levels of healthcare. We have indirect costs like transportation needs and even food for some patients, referring them to the Vicente Soto. Wala silang pamasahe, wala silang pagkain, at saka matagal yung paghihintay nila. They go there, they arrive there at 7, they are seen at 6 o'clock in the afternoon or evening. So, ano yung CAF? May possibility na ba na kami din maka-avail noon for our patients?
Thank you, Dr. Debbie. Okay, so actually that's a very good question. So the reason, like right now, that the Cancer Assistance Fund is naka-congest muna siya for the hospitals kasi basically we just started the CAF in 2022. So it's actually a program in progress. The second is, with the current limitation kasi with the government auditing rules and regulations, we are only bound to provide CAF to our DH hospitals. And even if we give CAF to like other non-DH hospitals, medyo masalimuot po yung requirements nila. A lot of processes. Pero definitely that would be something that we also want to consider, yung expansion of CAF to even to communities. Pero for now, the suggestion would be, ito po pumapasok yung critical role ng localization of the cancer law. There are some local government units that created their ordinance. Yung in example ko kanina, yung Quezon City, and I think right now, Manila City is also trying to do the same. In their ordinance is also the provision of a local cancer assistance fund. So the local cancer assistance fund will actually provide support to their residents, no, sa mga citizens nila for their hospitalization, even for their community. Kasi ang pera sa LGU din sa LGU siya galing mismo. Okay, so that's one thing. Pero definitely, as we go further for the improvement of the cancer assistance fund, the next big thing that it will be able to reach the community is through the palliative care. Yung in-example kanina ni Dr. Mark, no? Kasi in the revision of the Cancer Assistance Fund, we will also be paying for the palliative care services. And we're looking into creating that package that it will pay the palliative care services in the community. Okay, kasi yung hospital covered na ng PhilHealth, the usual MAIFIP, etc. So we want also to cover that in the community. Pero kukunti pa lang ngayon ang nakakapasa sa requirements and then the system structures needed for the palliative care services in the community. So I would suggest for LGU, Mandaue, push for your ordinance.
LGU is already doing that.
Yes
if we
po.
can, maybe
You can copy their...
touch base with them so we can learn how they do it.
Do the
Kasi
same.
mahirapan din kami sa amin sa COA, yung mga COA balls ba na paano yung pag-release ng meal allowance, paano yung pag-release ng transportation sa kanila.
Okay, yeah. We can link you with them or even you can do benchmark and visit Quezon City.
Quezon
City.
Thank you.
Thank you.
Okay, thank you so much. Are there any questions, Puff, from the crowd? Okay, we have
Another question.
Hello. So this is more of a general question. Wala si Dr. De Vera, but anyone could answer, I guess. So in her talk ganina, she mentioned about the different ways to treat cancer, right? Like chemotherapy, cancer surgery, radiation therapy, and these have side effects to the patient's jud. But quite recently, there have been advances in the treatment of cancer, particularly from the research of a South Korean team, saying that they've treated cancer by converting the cancer cells to normal cells. Ako lang curious question is, what do you think about it? And do you think it would take off in the near future for human treatment?
Hello, good afternoon. So I haven't read about the study, but currently we have our local guidelines and international guidelines, what treatment protocol that we need for our patients. Maybe in the near future we'll have that, but currently we'll follow our own guidelines. So most of our guidelines are based on what I have mentioned, the National Cancer, the NCCN, as well as per institution na guidelines that we have in terms of when to give the chemotherapy, the timing, then radiation therapy, as well as the targeted therapies that we have. So in our experience in the Vicente Soto, so naapata sa level of targeted and immunotherapy. Wala pataan ng conversion of cancer cells to normal cells, right? So wala pataan na, but we're into targeted therapy and immunotherapy. That's why it is very important ang kaning mga immunohistochemistry nato para guided ang atong treatment. This also lessens ang atong mga gipangkahadlukan ng mga side effects because targeted na ang ato ang mga treatment for this specific type of cancer. But sa what you have mentioned of converting cancer cells into a normal cell, wala pa taning abot ana nga level. Okay, follow-up question.
Speaking of targeted therapy, sir, Doc, curious question lang, specific ni siya. Do you also use machine or deep learning to murag personalized treatment planning since targeted naman jud for precision naman jud ang mga treatments in VSMMC?
Oh, yes. So, as part of my discussion a while ago, so we have the immunohistochemistry like ERPR, HER2. So, appeal na siya. So, targeted therapy, meaning if you're positive, the estrogen and progesterone, so more of the hormonal treat compared to the aggressive one nga you need the standard chemotherapeutic treatment. As well as if you are targeting the HER2 in reach. So, kaning HER2, this will tell us how aggressive the cancer cells are. Kung unsa ka paspas siya mo replicate or mo divide. That's why we have the HER2 or the trastuzumab nga treatment that will lessen. So targeted siya kung specific type or subtype of breast cancer ang imuhang ang patient or has, di ba? So that's the more a way of explaining it ng mga targeted.
Okay. So, thank you so much. So, no other follow-up questions? Okay. So, are there any other questions from the floor?
I think we have a question
Okay.
here sa screen.
Okay. So, the question is, given the persistent challenge of late-stage cancer diagnosis in many local government units, what practical strategies can be adopted by LGUs to significantly increase participation in early cancer screening programs, particularly for breast, cervical, and colorectal cancers? So I guess this is for everyone. Anyone can answer the question as well.
Good afternoon. As mentioned earlier, we have the screening test, right, the FOBT. I think it's readily available, it's accessible. And in fact, Vicente Soto has that one. I don't know with the level of the LGU, but this, I think, would be a bridge wherein we can catch patients early in terms of screening. Because mostly, as I have gone through my training in Vicente Soto, most cases are on the advanced stage. So it would have been better if you were able to enforce fully the screening tests in terms of the use of the FOBT because it's cheap, unlike the other tests.
Okay. So, Doc, FOBT is fecal occult blood. Okay, so it's a very simple and readily accessible tool in almost all local laboratories. So you can have your patients tested for that first. So are there any other from the doctors who would
Okay.
like to answer? Yes,
So
Dr.
we're
Tan.
talking about strategies, no? So maybe one strategy that we can apply is an free annual nga check-up to all sa ato ang mga subordinates. And then, you include this screening test. I think that's one strategy that we can maybe later on give to our local health unit. Libre siya tanan and i-include ang all nga mga screening test. It would be beneficial for all our constituents also.
Yes, I would agree on that. And on that line of screening for everyone, there's been a question, Doc, in the QR code from the floor. So they've been asking, I think this is from the LGU, that when they're done screening and then when they think that this patient already has warning signs or early signs of cancer, how can they successfully refer the patient to our institution or any tertiary institution for that matter?
So, with regards to cervical cancer screening, the strategy that we've been actually doing is, as mentioned in my lecture, that we are actually doing the CLAMS project or the hub and spoke, and using the hub and spoke model. So we have a centralized laboratory, and these laboratories have subunits that will perform the screening. So more or less, the strategy is more on awareness that these testings are available in their areas. So once, and the good thing about this is once they've been tested positive or there's any lesions that can be seen, can actually be immediately referred or can be treated at in the same day that is seen by the healthcare worker. And also, by that, we have to constantly train healthcare workers, not just doctors, including nurses, midwives, to perform these screening tests and do the procedure itself, like the thermal ablation. So that's it for cervical cancer.
For cervical cancer. I hope the question was answered. But if you still have follow-up questions, please feel free to stand and raise the question, okay?
I think also one of the strategies to encourage the constituents of the LGU is to have an information campaign drive, because if they get the wrong information, even if we have, like, I'm sure si LGU, you already have the free screenings. So with the wrong information, they might not even go to that free cancer screening. So I think the most important for the LGU is to give accurate information and to, the myths, but you have to tell them that it's not right. And then, screening is still best. So maybe that way, you can encourage them to participate in the cancer screening.
Anything to add, Doc? Okay, we have another question. Additional answer. Okay, sorry.
I'll quickly add na lang kasi I think it cross-cuts the realm of public health. So for the one who inquired about it, so basically I can just quickly summarize, for the LGUs that who really wants to make sure that screening and treatment are linked to care. Number one, you make sure you incentivize. So when we say incentivize, pag-isipan po natin, so how do we make sure na when people come, they get to have that feeling na, okay, may libre akong ganito. Some are even considering vouchers. Look at how Globe and Smart incentivize their customers, right? To continue to have their postpaid. Kasi every time that you renew them, may bago kang promo. So think something also with our screening. So how can the LG also incentivize in terms of like food packs or something? I know it's quite hard, pero that can also be possible. Number two would be finance. Yung sinasabi ng PhilHealth. So critical is really financing. Example, you could look at how Baguio did it. They are financing their FOBT and their fecal immunochemical test. Kasi they are using now fecal immunochemical test kasi it's more easier to test than the usual na FOBT na guayak. Kasi guayak would take around 6 testing pa processing. FIT only takes 1. One test lang tapos may results ka na. And it's community-based. Okay? So kaya siyang i-process ng local government unit. And please also consider, you might want, PhilHealth has already started the outpatient cancer benefit na package. And as of now, I think around 130 plus facilities are contracted nationwide. Consider looking into your local government unit. Baka meron na doong facility na contracted so that you can, navigate your clients to that facility to get their screening because that's already free and covered by PhilHealth. And then the third would be navigate. You have to ensure na people kasi kailangan may daan, okay? May daan para alam nila kung saan sila pupunta. Taguig City, for example, has dedicated navigators for their breast cancer screening. So ang lakas nila, mayaman sila, pero they use their money to hire navigators. So that's something that maybe the local government, other local governments also can consider. And third would be, as much as possible, try to use yung new technologies and that are really fast and uses minimal resources. So for example, for HPV DNA, for cervical cancer, ang ibang local government units, they still shift to the VIA. So suka. So imagine you would need your doctor, you would need your speculum, bubuksan mo pa yan, and then you look at the cervix, no? So it would take around 30 minutes, tapos i-disinfect mo pa. But if you have already the HPV DNA that costs around 1,000 or 2,000 pesos in some of the local government units, that's self-collection. You just do the counseling, give the kit, parang COVID swab, go to the CR, swab it yourself, put it back in that receptacle, send it to the laboratory. After 2 to 3 days, you have the result. Positive, you refer to Vicente Soto for treatment. So part of the navigation is to make sure also yung healthcare provider network, yung lahat ng mga local government, di ba yung mga LGU, dapat may healthcare provider network tayo. And it must be really clear saan kayo dapat mag-refer. So for Cebu, it's mostly in Vicente Soto. So if you have contact there, di ba, it's easier for you to call your contact sa hospital na, okay, may i-refer kaming ganyan. So I think that's just some of my quick recommendations for that question sa local government unit. Thank you.
Thank you so much, Sir Vince.
I think we have another question via QR code. Okay, question is, what will happen to the UHC when Yakap is now more popular? Again, what will happen to UHC when Yakap is now more popular?
I'm sorry. Who sent this question? Pwede paki-expound? I don't get it. Like, what happens to UHC when Yakap is more popular? See, Yakap is technically it's under UHC. It's a program of PhilHealth, but then PhilHealth is part of UHC, DOH. So technically it's the same. So I guess nothing's gonna happen to UHC, even if mas popular si Yakap now. So I don't know if I'm answering it right, but that's how I see it.
Okay, I guess na-answer po ni Doc, ni Doc, no? Okay, another question via QR code.
Maybe they were thinking na two different unsa, but yeah, it was already answered that Yakap is under UHC.
Okay, another question. I would like to address my question to Doc Lucero. Is there an online course about end-of-life care, especially to nurses? Again, I would like to address my question to Doc Lucero. Is there an online course about end-of-life care, especially to nurses?
Yeah. Hello? Hello. Okay. Actually, DOH has been very active na regarding not just end-of-life, no, but the whole palliative care package. We have already our team last year, but naalami gamay na mga we have to fix something before we rule out. Our target is within second to third quarter of this year. We will go out sa mga LGUs. We will make kanang team, no? It's a team of doctor, pharmacists, nurses, social worker, and social worker, pharmacist, nurse, and dietitian. So our goal is, again, continuity of care, and of course, we will assess also patients na needed o na i-step up or i-escalate na mo ang referral. No? Our target would be I think Tri-Cities. This is Tri-Cities and LGUs. Hopefully, we can start by second quarter. And it is funded by DOH. So, kuha na siya 2 weeks na training. No? It's not just about end of life. It's about symptom control, counseling, how to assess ang nutrition, no? And of course, how to navigate. That's why it's a whole package. And patient navigation is always our loophole manggod before. Kaya usually we will wait for the patient to come to the tertiary or ma-refer sa tertiary. But now we will go down sa grassroots youth area. And of course, we will empower you because ang point is, masustain na mo later on. And we will give you certificates also so that if ever na you venture out to another, I mean, this is lang, if ever na we'll venture out for another greener pastures, you can have that one also. But again, the point is, there will be a rollout maybe this year. So the DOH has been very active in pushing us regarding that one. No? And ang goal is really service delivery also for mga far-flung areas. And of course, before we go out also, we have to emphasize also the availability of medications. And just what itong question ganina na namangyuban good na yung mga side effects, and more likely ang mga medications are not available in the far-flung areas or even sa mga tri-cities, no? Kana siya.
Okay, thank you, Doc Lucero. I think that was the last question, no? From our buyer code. Okay, we have a last question from Doc Van.
Yeah. Thank you. Thank you to all the speakers. No, very enlightening on topic, although there could have been more time to delve on certain topics more. Having said that, I'm really interested in terms of the end-of-life topic of Dr. Lucero because aside from destigmatizing cancer, the screening, and the treatment, end-of-life topics really are something that's still very much taboo, even between the doctor and the patient. But we understand the doctor and the patient question. The problem is if it's the family and the doctors who are now talking, because we all know that cancer is a very consumptive illness, no? Not just for the patient, but also for the family. So how do you navigate this, Doc, in the point of view of end-of-life care or hospice care? If it's the family who would open up na i-hospice or end-of-care na lang na, end-of-life na lang ang patient, but the patient would still tell you, no, I would still like to have more options. Now, how do you, as a hospice or as an end-of-life expert on that, because usually these are the topics that are being brought at the community level during the discussion with the family, with the in terms of navigation, because the family would say nga, wala na yun may kwarta, Doc, pero si mama or si papa or biskin pa would still want to fight on, but we as a family could no longer support. So would hospice come into that conversation, or who would now, how does that conversation go about in terms of end-of-life care? Because isod po kayo nga, ang pamilya nga garon, but the patient would still fight, or other way around gihapon, the patient would say nga, I would no longer, I'm comfortable with this, Doc, mamatay na ako, but the family would still insist on that. So if there's a problem between the two, the patient and the family, in the interest of prolonging life, how does end-of-life navigate this particular reality, Doc? Thank you.
Yeah. First of all, Doc, thank you for the question. No? First of all is, we have to advocate for the patient. No? That's our legal responsibility. Second is that it's about communication. Okay, I always view that as is something wrong with maybe ang understanding towards the condition. Second, third would be, again, it is, I agree na it is really emotionally, financially, and psychologically draining for patients, and not only for the patient and for the family. I mean, it's a community. No? With that is, we are trained to do, actually, regardless of any type of, namangayuban na symptom control ang referral, but again, we always go back to the, we call that the disclosure part. Okay, we will always go back then. When we do family meeting, and we will also advocate for this, family meeting, we need the three, no? Aside from the patient, we need the patient's primary caregiver, and not just the one who takes care of the patient, but usually it's the kanang sa family bitaw na muna siya last scene, admit na siya, kuan ka, so kana siya. Another one, the main financial provider, kay aggressive ang patient pero walay capacity. So the third one is the surrogate decision maker. Okay, we plot it out. Of course, we go back to the disclosure part. Tanawa na mo if wala ba'y misperception. Kay sometimes good, ang problema na is dili sila realistic goal. with regard to the present condition, like advanced stage cancer na. Now, you have to, kuan manggod, kana yung, by the way, that's collusion, Doc. We call that term collusion. Kana bitong, kanang sikritoong kag duol sa family na, Doc, pwede dili lang na kung ano, Doc. So, that's usually, and you know why? Their thinking is they have to protect the patient, wherein it's not really protecting the patient. So it is where we come in. Again, the goal here is not to cut ties, dili mo pwede awayon. Ang goal here is you have to have same thinking, you have same perception, and at the end of the day, same goal. So family meeting na siya, Dok, ang mong buhaton. And of course, with that katong kailangan na mo, end of life, again, I agree, it's very taboo. Taboo dyan na siya, especially sa Pinoy. And when you say, manggod na give up, marag, allergic kayo. Diba? Muna ingon na, mahurot na tanan. Basta lang judok, buhaton tanan. But you have to contextualize mga what is buhaton tanan. Like, unsa may goal nimo in the first place? Hotdon lang nato ang resources, or you want to have you have to specify that one. You have to contextualize, and at the end of the day, it should be a win-win situation. It should not be a compromise. No, sometimes ang good na amo lang dili na to suryaan ang kanidapita kanila atong i-offer para dili na siya mo ngadto pa sa Cebu para no. Again, our foundation is truth telling. We have to be honest, we have to be straightforward, but then again, we have to be compassionate. And it's really hard, I agree, no? Lisod kay na siya in the context of kanang doctors kay we are trained manggod biomedical illness, but the psychosocial aspect wata na. And mind you, regarding aning kanang screening, it's usually the kanang health-seeking behavior ang problem. Okay? Ang kana manggong mga health teaching, it's not just a one-time, big time na kanang process. It should be sustainable. Kaya di man pwede magsigil lang may kanang sana siya, kanang medical mission. That's not the point, di ba? We have to sustain this one at the end of the day. Kaya para bisa pagwala na, and it's working. So, psychosocial aspect, you have to train our doctors, especially the frontliners, kamo, no? To, ayaw kayo mo diri sa biomedical illness. Kaya anyway, point is, you have to address manggod. Actually, if you will ask that, dili ba ang mas ang iyahang ningiyatuan? Usually, iyang silingan namatay kay tungod kay nahadlok siya. So that's why they will go to the hospital at 2 a.m. It's not really the kuan makaingan 2 months naman. It's usually the psycho-emotional aspect. So you have to be trained on how to address that one. Para nindot kay dapat manggod ang patient should view the doctor as kanang of help ba kita. Dili kay warta na po ni. I mean, sorry to kuan that, but again, that's the point.
Last one question.
Okay.
Actually, it's not a question, Doc, but I agree with you, the psychosocial training of the doctor, especially of the part of the private doctors. Because I, for one, my mom is a cancer patient, then he himself is a doctor, and he told my mom, if wala pa ka nagpatambal, you're 6 feet below the ground. So, mag-iyan ang gipatay akong mami sa words pa lang, niya, doctor siya. So, I was really, nasuko jud ko, that I really wanted to bring it up to my sister. Then, mingon siya nga, wala na lang, we chose peace rather than gubot, but dili gid untaing ana. Because you're a doctor and you have the authority. You can bring the patient to life, or at least you have a good energy. But if you're a doctor that you already killed the patient with your words, di na naganahan mo kuan ang pasyente. So I agree with that, Doc. Hopefully naa siya training, especially for the private doctors, because I know the MHOs, the government doctors, they're good in the psychosocial already, because we have already the training. But the private doctors, murag, they lack of that.
Okay, thank you so much, ma'am.
Can I respond?
Yes,
go ahead.
Okay, again, regarding that's why in cancer management, it should not be a one-man army. Because again, we have different mode fields of expertise. Okay, it's a multidisciplinary team approach. we disclose, the oncologist will tell you the options. Of course, if you will not pursue the treatment, no, the aggressive modifying treatments or any one, then kami na po mo explain on what. Again, it's really kuan siya, kana siyang multidisciplinary team effort din siya. Then, as to the kaning training, again, that's muna mo ang advocate karon na we have to start from kanang early pa sa med school. Wa mo na. Biomedical illness mo yun. First year, it's about physiology, pathology, but then again, sawon lang ka. Grabe ka explain about biomedical illness. Muni siya na. Igabot sa ilaha, naisilingan, uy, magpakuan ka, namatay ba? Wala na. Dili na mo follow up. Again, that's the point. Yeah, that is really what is happening. And heart biya punta kay grabe kiming grabe kitag training, then sawon lang tag neighbor. I think we have to think we have to be open also. No? There is something wrong. And we have to, of course, we have to uplift also our kanang, we call that psychosocial skills. And we are training, we are kanang, again, no, it's an institution. So lisod kaya na siya change overnight. But again, we are doing our best. No? Hopefully, I'm sorry for your I'm sorry for your experience, no, but it should not be like that.
Okay. Thank you so much, Doc. And for those who gave your questions, no? An applause, please.
A round of applause for everyone, please. This has been indeed a very fruitful part of the program, though this is still not the end, but definitely there was a beautiful exchange of question and answer from the floor and our speakers. Thank you once again,
Thank you so much,
doctors,
doctors,
for your time.
And before we proceed to our second part of our program, we will have a 5 minutes break, okay, for you to freshen up and be ready for our awardings and another set of talks. Okay, this has been your host for the first part. My name is Age.
And I'm Dr. Jabal Bernabe, and it has been my utmost pleasure
Yeah, okay.
to be side by side with Zagi. And thank you so much for having us this morning and this afternoon.
Thank you so much.
Take care and God bless everyone.